Hello, hello, test, hello, testing, hold on. Hello, 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 hello. ಸಾಕಾಯ್ತದ ಅಲ್ಲ ಅಲ್ಲಿ ಅದು ಕೊಟ್ಬಿಟ್ಟು ಜಾಸ್ತಿ ಬರ್ತದೆ ಎಸ್ ನಾನು ಎಕ್ಸೆಲ್ ತರಬೇಕಿತ್ತು ಹಲೋ ಹಲೋ ಸಾಕಾ
Check one two. Check one two. ಇದೇನ್ ಹ್ಮ್. Check one two. Check.
फर्स्ट सर सर आपने प्रोग्राम फर्स्ट ये दिन देना है then you follow hand by foot whoever speaks continuously then they will stop to very good. She's at that point. She's at that point. बोला मैंने बोला मैंने
Hello, hello. So good morning, one and all. Just give us 5 minutes. We are waiting for our first chairperson, and we'll be starting within 5 minutes. So good morning, one and all. Let me thank you all for joining this Sunday morning. It's a very unique opportunity because we're going to deal with a single disease. Because of which now many patients are getting diagnosed. The target of this brief CME today would be to raise awareness about this condition, to give clinical scenarios as to how we can all diagnose this condition and how we can all treat. The good thing today is that the definitive therapy for this condition is now available in India. And that is why there is more and more that we start diagnosing these patients. Without wasting any time further, I would like to start the sessions. And I would first request Dr. Jyoti to introduce our first chairperson and we can begin the sessions. Thank you, and I wish you a wonderful scientific session.
A very good morning to everyone. Our first session for the day is on classification and approach to a case of angioedema. And for this, I would like to invite Dr. Sujala Sachidanand Aradhya to chair this session. Dr. Sujala is a consultant dermatologist at Sujala Polyclinic and Labs, Bangalore. She's also the secretary of the Bangalore Dermatological Society, treasurer of the IADVL Karnataka, and chairperson of the IADVL USL. Over to you, ma'am.
A pleasant good morning to one and all. So here we are gathered today for the CME on hereditary angioedema, being hosted by the Hereditary Angioedema Society of India, co-hosted by CME Minister and BDS, Bangalore Dermatology Society. I would like to invite the first speaker for the session today, Dr. Ankur Jambul, who is the Assistant Professor of Department of Pediatrics and Clinical Immunology and Dermatology, Allergy Immunology Unit at Department of Pediatrics at PGI Chandigarh. Over to you, Doctor.
Thank you, Ruxila. Okay, so good morning, everyone. Welcome to the CME. You must be seeing some discrepancy. I think, there was a name of Professor Sunil Dogra who was supposed to talk about this subject, but because he's busy in another conference on leprosy, which is going on in Bangalore, so he'll join a little late. So he'll be here for the last panel discussion. So you'll definitely be able to hear his opinions, his expert opinions about this disease, but I'll be speaking on his behalf. I'm sure I'll not be able to speak as good as he can speak, but I'll definitely try to do justice with this subject. Before I start, I think I wish to thank Esther CMI and Dr. Sagar and his team who took the lead to organize this CME, and Bangalore Dermatological Society, Dr. Sujala, who, like, I'm sure if you're a dermatologist, you must have seen hundreds of messages from her, convincing you to come for the CME. And I'm sure you never regret coming to the CME because this is such a unusual topic. I think most people, whoever I have talked to about, they think it's limited to the books and you never get to see a patient of hereditary angioedema in your practice. But I'm sure this is a notion. You all know that your eye sees what your brain knows. And here we are to teach your brain that this disease exists around you, and you just have to open your eyes and see. And I'm sure you will be able to diagnose these cases which are being missed like anything. So here I am to talk about, I think it's first thing that is most important is to understand what is angioedema and what is hereditary angioedema. And then we'll talk about how do you diagnose, and then we're going to talk about how do you manage this disorder. So nothing to disclose, no conflicts of interest. But I just would like to start by asking, like, how many of you have actually seen a angioedema, not hereditary angioedema, but an angioedema? Okay, and how many of you have seen a case of hereditary angioedema? Just one or two. Okay, and how many of you have actually managed a case of hereditary angioedema? Right. So, and I'm sure, a couple of months down the line, all of you will be seeing such cases, and you will be diagnosing these cases. This is not a lecture, and I would request, if you don't understand anything, stop me at that point of time. And if you don't stop me, maybe I'll be asking you some questions if you don't stop me in between. So everything starts with a definition, and angioedema, definition of angioedema, it's important to understand, because if you don't understand the definition of angioedema, you will not be able to get what are the differential diagnoses. Patient comes with swelling. Swelling can have several reasons. So first of all, it is important to understand the definition and the classification, because the mast cell mediated angioedema, commonly known as allergic angioedema, is much more common than hereditary angioedema. So you have to understand, patient who has come to you with swelling, when do you call it as angioedema, and when do you call it as allergic angioedema or hereditary angioedema? And then major part of my discussion, and one major part of the later talk, would be how do you differentiate between various types of angioedema? That's the most important thing for you to know today. And we'll have excellent case presentations by Dr. Sagar in the end. How do you differentiate the two entities? And then we'll talk about clinical manifestations of hereditary angioedema, book picture, as well as what has been our experience in Chandigarh, and very alarming epidemiology and the current state of this disease in India. Okay, so let's start with definition. Angioedema is a localized swelling. It is not a generalized swelling. It's a localized swelling. As you can see in this picture, this lady developing angioedema of the lips and the face. It is self-limiting or episodic. It doesn't mean you don't have to do anything with this disease. You have to treat. But even if you don't treat, angioedema is going to subside. It's not going to persist for months or weeks. It's going to subside in few days. It's non-inflammatory. It's not like cellulitis, which is inflammatory. It's not like the inflammatory edema you see in patients with vasculitis. It is non-inflammatory, and by definition, it's edema of the subcutaneous and or submucosal tissue caused by increased leakage of plasma from capillaries located in deep layers of the skin and the mucosa. Now, this comes with differential diagnosis, and there are, I think, more than 15 differential diagnoses that you can encounter. They are not very common. Whenever you see angioedema, it will most likely be either allergic angioedema or bradykinin-mediated angioedema or hereditary angioedema. But yes, you have to keep these differential diagnoses in mind. And I'm going to show you a couple of cases in my next slide, wherein we also got confused initially that are we really dealing with angioedema or is it something else? Inflammatory edema that you see in sometime in patients with vasculitis like inox colon purpura. And I'm going to show you a case of this. Dress syndrome can sometimes present with an episode, a swelling which looks like angioedema. Nephrotic syndrome. It's not difficult to differentiate nephrotic syndrome from angioedema, but yes, it's a differential. Nephrotic syndrome will have generalized swelling. For dermatologists, I think identifying granulomatous cheilitis it's a spotter for them. But for pediatricians, I'm sure there are a lot of pediatricians here. This entity should also be kept in mind. And then patients with contact dermatitis can have angioedema. Hypothyroidism is something, when you don't understand anything, I think rule out hypothyroidism, especially when they're presenting with swelling of the tongue. And then hypocomplementing urticarial vasculitis, extremely rare. And then several infections can sometimes present just with a swelling episode. I'm going to show you a couple of cases. This boy we saw, I think 2 weeks ago, 4-year-old, he came with swelling on the hands, and he was actually referred to us as angioedema, hereditary angioedema, got a complement levels done. And when we examined this child, he had rashes on the legs. And 2 months ago, we also saw another child who had angioedema of the hands and feet. He also had the rashes, and he also had pain abdomen, again thought to have hereditary angioedema. So if you have, angioedema along with rashes, this is not the bradykinin mediated or mast cell mediated angioedema. To think of vasculitis. Now, this is a very unusual case that we saw a couple of years ago. This child had some reaction to some drug. This is an infant. And then if you can make out, these are a few, when these rashes started subsiding, he started developing these rashes. And I'm going to talk about these rashes. So these are erythema marginatum. These were classically described with rheumatic fever. And now because rheumatic fever is almost gone, so this is one of the common reason for developing erythema marginatum. So hereditary angioedema is a common reason for erythema marginatum, and we'll talk about this in my subsequent slides. And this patient also had these edema over the lips and on the eyes. We could not find any etiology for these angioedema in this patient. This patient did not turn out to be hereditary angioedema. So this was possibly some remnant of DRESS syndrome that he had, secondary to some drug reactions. So this is another differential that you need to keep in mind. And this is, I think this is a spotter for dermatologists. This is granulomatous cheilitis. Again, this boy was referred to us as a case of hereditary angioedema. What is peculiar? This patient had lip swelling, which was not coming and going. It was persisting. It was persisting for a few weeks. And this is not angioedema. Angioedema has to subside, has to come back, has to subside, has to come back after a few days or weeks or months. So these are some of the cases that we have seen, and that's what I'm going to share. But yes, whenever a patient comes to you with swelling episode, do keep some of these differential diagnoses in mind. This is how simplified way of classifying angioedema is. And we often call mast cell mediated angioedema as the allergic angioedema, which is okay. I mean, it is an allergic form of angioedema, but the more technical term is mast cell mediated angioedema. It's not histamine mediated angioedema, because histamine is one mediator of angioedema. There are several other mediators of angioedema in allergic forms of angioedema. And I'm not going to talk about this form of entity too much today, but I'll just tell you about how do you differentiate mast cell mediated angioedema from bradykinin mediated angioedema. And for a clinician, I think that is the most important thing. What is very important is, this particular line, approximately 10% of patients may have angioedema as the only presentation. They do not have urticaria. They just present with angioedema, and then it becomes a little more clinically difficult to differentiate it from bradykinin-mediated angioedema. But there are clinical features by which you can differentiate, and I'll talk about this in my subsequent slides. The other form is bradykinin-mediated angioedema, and into that, the most common form is hereditary angioedema, which we'll be talking about in detail. I'll briefly talk about acquired C1 inhibitor deficiency here. So if you are an adult physician, or if you're an adult, dermatologist dealing with adult patient, if you have a patient who comes with angioedema starting from 35, 40 or 45, 50 years of age, so in the 4th or the 5th decade of life, and which is looking like bradykinin-mediated angioedema, you need to think of acquired causes and not the hereditary causes. The hereditary causes usually start very early in the childhood, and they don't present for the first time so late. So what are the common acquired C1 inhibitor deficiency? So acquired C1 inhibitor deficiency means you have antibodies against C1 inhibitor protein, which leads to decreased C1 inhibitor protein levels. And this commonly happens in patients with autoimmunity like systemic lupus erythematosus. It also happens in patients with lymphoproliferative disorders like lymphoma. What is very important here is you may have angioedema at the first presentation, and a couple of years down the line, you start showing manifestations of lymphoma. So if you have an adult patient who's come to you with bradykinin-mediated forms of angioedema, keep that patient on follow-up. This patient may develop lymphoma in next few years. That's very important. And you should always rule out autoimmunity, especially systemic lupus erythematosus in these patients. So I'll also talk about AC inhibitor-induced angioedema. So approximately 1% of patients who use AC inhibitor tend to develop AC inhibitor-induced angioedema. This drug is now very, very commonly used. Again, this is a commonly used drug in pediatrics. We use it very, very often, especially in patients with SLE, especially in patients with nephrotic syndrome. But somehow children do not tend to develop AC inhibitor-induced angioedema. It's mainly in adults. So approximately 1% of adults who use AC inhibitor tend to develop angioedema. It is important to know Because if you have a patient who has developed angioedema, do ask, are you taking any antihepatitis? Are you taking enalapril? Are you taking any of the ACE inhibitors? Because if you just remove that ACE inhibitor, your angioedema is gone. So it's very, very important to take that history if you have a patient who comes with angioedema. And what is the mechanism? This I'll talk when I talk about the pathophysiology of this disease. And despite doing everything, some of these angioedemas are difficult to define, but they are not that common group. And then we call them as angioedema of unknown etiology. We treat them most often as allergic angioedema with all kinds of drugs. But yeah, it is difficult to put them into any particular category. Okay. So this was a more simplified classification. This is a more recent classification. This is not yet into publication, but this is the work of Dr. Evner Resha from Israel. And I'm sure you're going to see this classification very soon. So this is based on endotypes. So they've classified angioedemas into 5 different types. So one is mast cell or mast cell mediated angioedema, which we just talked about. Then there is bradykinin mediated angioedema, which includes hereditary angioedema and the rarer types of hereditary angioedema. There is third class, which is vascular endothelial dysfunction. And I'll talk about these when I talk about HAE, because there are certain genetic defects in HAE that have been now described, wherein there is some form of vascular dysfunction. And then there is a fourth class of drug-induced angioedema. And then, as I said, you do whatever, but sometimes you are unable to classify a patient into any particular class, and then you call it as idiopathic or unknown angioedema. So this is something that you're going to see in publication, maybe sometime this year. Now, this is the most important slide for a clinician. How do you differentiate? And let me tell you, the differentiation is clinical. You don't need any lab test to differentiate mast cell mediated angioedema from bradykinin mediated angioedema. And I'm going to talk about all these points one by one. Age of presentation. If you've managed a patient with allergic angioedema, you must have seen these patients come at any age. They can come at any age for the first time. And it's very, very common. So if you talk about bradykinin mediated angioedema, and especially about, so when I talk about bradykinin mediated angioedema today, I'll mostly be talking about HAE. I'm not going to talk about the acquired causes of C1 inhibitor deficiency. Most forms of HAE have symptoms starting in the first 10 years of life. So 50% patient will have symptom onset in the first 10 years of life. So it's a pediatric onset disease. It's a pediatric onset disease. So if you're a pediatrician, be happy about it, because most of these patients will come to you for the first time. So, but that doesn't mean that all patients have symptom onset in the first 10 years of life. We have patients who have symptom onset in second decade, third decade, fourth decade. We also have patients who are affected, who have abnormal lab results, but they are not symptomatic even in their 8th decade of life. So it's variable, but by general rule is that most patients will become symptomatic in the first or second decade of life. The most important point that I follow when I want to differentiate from allergic, the allergic forms of angioedema from HAE is presence of urticaria. You all know, if you have urticaria, then this can't be HAE. This has to be mast cell mediated angioedema. And then the second and third point, onset of swelling. If you have a patient who comes with swelling developing early in the morning, he or she says that I get up in the morning and I have a swelling. They say that swelling starts and it evolves very, very rapidly in few minutes to few hours, and it subsides usually within 24 hours. So that is a typical clinical manifestation of mast cell mediated angioedema or allergic angioedema. While what happens with HAE? This is what happens with HAE. The swelling evolves gradually over few hours, 12 to 24 hours, stays for few days, and then resolves in 2 to 5 days. So it's a slow evolving disease and subsides slowly. So that's the natural course of most angioedema episodes in patients with HAE, right? But there is a star over there that says that if you have a patient with HAE who develops laryngeal edema, who develops abdominal attacks, now that can be very, very rapid. So you don't have to be complacent about it, that, okay, a patient with HAE will always develop swelling gradually. So let's be complacent. Let's treat them when they develop the full episode of swelling. No. Patient with HAE can develop very rapidly fatal laryngeal edema and can have very rapid onset of abdominal attacks as well. Pruritus and urticaria, as I've already talked about. So this is a feature of bradykinin mediated angioedema or HAE, but not a feature of oh sorry, it's a feature of allergic angioedema, but not a feature of HAE. There may be a little bit of pruritic-like symptoms in patient with HAE at the beginning of the symptoms, but it's not a major manifestation. Now, most patients with allergic angioedema have symptoms in the face, while most patients with HAE will have symptoms in the peripheries. They also have facial attacks, but most commonly they have it in peripheries. The laryngeal edema, and if you have laryngeal edema can be seen in patients with allergic angioedema. Believe me, we've talked to so many people about this. That have you seen a death because of laryngeal edema in a patient with allergic angioedema? No. No one because of laryngeal edema dies in a case of allergic angioedema. While death because of laryngeal edema in HAE is very common, very common. And I'm going to show you those data in the end of my presentation. So if you have a family history that somebody died because of laryngeal edema, this can't be anything else. It has to be hereditary angioedema. Now, earlobe involvement is something which is a common presentation in mast cell mediated angioedema. It doesn't happen in patient with HAE. Recurrent abdominal symptom, genital swelling, is common in HAE. It doesn't usually happen. It can happen, but it's not common in allergic forms of angioedema. I'll talk about prodromal symptoms and triggers subsequently in my presentation. But if you have a patient with allergic angioedema, do not give them NSAIDs. Do not give them NSAIDs because NSAIDs will trigger angioedema in these patients. NSAIDs are not usually a common trigger in patients with HAE. There are other triggers which we'll talk about in subsequent presentation. And I'll talk about family history later. But if you have a family history, especially a family history of laryngeal edema, death because of laryngeal edema, don't even think of differentials. It has to be hereditary angioedema. And I'll show you some of the scary family trees that we have existing in India. Response to antihistamine and corticosteroid is something that you have to check carefully. Patient with allergic angioedema corticosteroid. The patients with HAE also show that they respond to corticosteroid. But why do they respond to corticosteroid? Because of this, because they use corticosteroids somewhere around this, and then they feel, yes, my episodes tend to get better with steroids because it's a slow resolution on its own. It is not because of use of steroids. So these are the, I think, the most important points by which you can differentiate the two forms of angioedema. But allergic angioedema or the mast cell mediated angioedema is still the most common entity. It's still the most common entity. Hereditary angioedema is still rare. Okay, so these are some of the pictures. You can see on your left, you have patients with urticaria, angioedema, little bit of redness, earlobe involvement. This is mast cell mediated angioedema. While on your right, you have patients with hereditary angioedema, unilateral swelling, bland swelling, no redness, no urticaria. So this is how these patients present to you. Okay, and it's completely clinical. Till now, no laboratory investigations. Differentiating these two is completely clinical. Is there any question that you want to ask before I proceed? Or you want to share your experience with this? Anyone? Okay, so can proceed. Am I taking too much time? Okay. Okay, fine. I just want to talk about little bit about history of hereditary angioedema. So most of my talk subsequently would be based on hereditary angioedema. And please let me know if you don't understand anything, if you want to ask anything, just stop me and ask me. Why I want to talk about history of HAE, it's important to know history of everything. But there are certain myths that I want to clarify based on, what is the history of HAE. So it was first described as episodic angioedema in 1843. And you must have read somewhere Quincke's disease. It is somewhere still written in the textbook as Quincke's disease because Quincke described in 1882, he reported a case on swelling disorder. But for the first time, the hereditary nature of this disease was described in 1888 by William Osler. And you can see the term hereditary angioneurotic edema. So why neurotic? Because at that point of time, it was not known that there is a protein which is deficient in your body, which is causing these swelling episode. It was rather known that stress causes swelling in these patients, and that's why a term neurotic was added. But now we know that it's a protein which is deficient. It's not neurotic. Stress is one of the triggers. So hereditary angioneurotic edema is not the correct term. Hereditary angioedema is the correct term. Okay, so, and then it took many, many years to describe that the C1 esterase inhibitor protein is deficient in these patients. And it took again many years to describe that the gene which is defective is the SERPING1 gene. So that's how the history of HAE evolved. The history of HAE in India, if I start talking about, it started in 1992 when the first case of this disease was reported. So we were very, very late in reporting this entity in India. So what is HAE? HAE is a life-threatening disorder. It is not potentially life-threatening. It is a life-threatening disorder. People in India are dying because of this disease. It's clinically characterized by recurrent episodes of swelling over eyes, lips, hands, feet, genitalia, and gastrointestinal system. Can anybody tell me which organ is not affected in patient with HAE? Never affected in patient with HAE. Can anybody tell me? So for some reason, lungs are not affected. For some reason, the brain is not affected. For some reason, the kidney is not affected. For some reason, the heart is not affected. We don't know why. We don't know why these patients do not develop edema in the lungs, why they don't develop edema in the kidney. But yes, some of these organs are not affected. But otherwise, any part of the body system can be affected. And the most life-threatening is the laryngeal edema. So if they develop swelling in the larynx and they just choke. Most attacks are painful, they are unpredictable, debilitating, and often require emergency medical attention. And because of all this, most patients with HAE have an impaired quality of life. As I said, this is good news for pediatricians that most patients will come to you for the first time because the onset of most patients is in the childhood. So 50% patients present for the first time before the age of 10 years. But most patients are not diagnosed in the childhood. So that is our job, to diagnose them in childhood when they present with their first episode. It has been our experience as well in managing about 200, close to 250 patients with HAE in our center, that the frequency and intensity of this disease tend to increase during puberty. It's probably related to the hormonal influence. For some reason, the swelling starts unilaterally, and many of these patients report trigger. Many of these patients report prodromal symptom, which I'll talk in my subsequent slide. But what is extremely important here is to know that this disease is highly unpredictable, highly unpredictable. As I said, we have patients who start having symptoms at the age of 2. We have patients who do not have symptom at the age of 70. For some reason, we don't know. We have patients who are symptomatic in the sense that they have 10 episodes in a month. We have patients who have no episodes in 10 years. We have patients who have symptoms very, very frequently, and 1 year down the line, they're asymptomatic for a few years. So this disease is highly unpredictable. What makes it unpredictable, we don't know, but this is a highly unpredictable course that these patients follow. So these patients report triggers, not all, about 50% patient in our experience as well, they report trigger, and these are various triggers. So trauma is a common trigger. So for example, if I'm just walking like this, or if I hit like this, I'm likely to develop a swelling over here if I have HAE. So even a minor trauma can lead to angioedema in these patients. Surgery, viral infection, in females, many of these females report menstruation as a trigger, very common trigger. Use of estrogen. So I remember I got a call from a patient a few days ago, an adolescent girl who had polycystic ovarian disease, and she was prescribed estrogen. And fortunately, parents contacted the doctor. My daughter has HAE. Should I give this drug to her? I said no. Just remove estrogen. Give anything else. So if you have a patient with HAE, please do not let your gynecologist or anybody else prescribe estrogen, because this drug will flare their symptoms like anything. Emotional stress, many patients report. Physical exertion, food also, some patients report, but it's more subjective. Food really has nothing to do with episodes of hereditary angioedema. It's more subjective. So patients who take spices, who take more protein-rich food, they do report aggravation of their symptoms. Just like you must have heard of what prodromes in patients with epilepsy. And it's very important that when you have a patient with angioedema, do ask about prodromes. They do report prodromes. They do report that I have a feeling that I'm likely to develop an angioedema. This doesn't happen in mast cell mediated angioedema. This happens only in hereditary angioedema, that they can predict to some extent that they are likely to develop an episode of angioedema, because it's a slow growing disease in most cases, and that they predict. And this is a list. I don't want you to go through this list, but I just want to show you one. This is an erythema marginatum kind of rash, and this is a very common symptom in Western population. About 50% of these patients report erythema marginatum like rash before they develop an angioedema. I think probably because of our skin color, in our experience, we've been able to identify this in about 20 to 25% of the patients, not more than that, but it's still a common symptom. what is important to know here is that this erythema marginatum like rash can easily be confused with urticaria. So you have to be careful. What is urticaria and what is erythema marginatum? Because the differentials are completely different. Okay, so family history. It is not uncommon to see that a child comes to you with angioedema, and then you get to know that the parents, the grandparents, the great grandparents also have the same disease. It's very, very common. So this is the kind of family tree that we see. And this family was diagnosed when this girl started having symptoms. And you look at this family, there are 10 deaths because of hereditary angioedema, and there are at least 13, 14 family members who are still living with this disease. And it took so many years for this family to get her diagnosis. That is what we have to, get rid of in our country. So abdominal symptoms are again a major manifestation. So just like these patients develop swelling in the hands, feet, and any other part of the skin, these patients can develop swelling in the abdomen, the gastrointestinal tract as well. And these patients do present with excruciating pain abdomen, sometimes with vomiting and diarrhea as well. And this pain abdomen is really excruciating. Some of these patients have predominantly abdominal symptoms. Now, somebody asked me, like, can they present only with abdominal symptoms? Yes, theoretically, yes, it is possible. But as I said, in our experience of managing about 250 patients, we haven't seen any patient so far who is presenting only with abdominal symptoms. They do have some or the other cutaneous symptom as well. But theoretically, yes, it is possible. If you have a patient who's presenting only with unusual abdominal symptoms, presenting with abdomen, with explanation, for 2 to 3 days, good point to rule out hereditary angioedema in these patients. Laryngeal edema is potentially fatal. Approximately 50% of patients will have at least one episode of laryngeal edema, and even the first episode of laryngeal edema can be fatal. In the past, the mortality because of HAE used to be 30%. I think it is still the case in India, and I think it's a potentially fatal disease in India. Now, these are some of the less common manifestations, which I think we don't really need to talk about. This is the most complicated slide that I have, but I'll try to simplify it. I'll talk about the pathophysiology because it's important to know pathophysiology of this disease so that you can understand the management of this disease when I talk about management later in the presentation. Is there anything that you want to ask, or is there anything that I want to clarify? Anything that you want to share before I move? Yeah, please. Sorry, what? Okay. Sorry, who presents with croup? Okay. No, that is different. That is different. No. So again, as I said, just like abdominal symptom, which theoretically is possible, they can have only abdominal symptom as the presenting manifestation. They can have laryngeal edema as the presenting manifestation, but they will have some or the forms of peripheral edema as well. They will not present only with laryngeal edema. I mean, that can be the first manifestation, but subsequently they will have other forms of angioedema as well. Okay, so I'll just try to simplify it. On your left, you see a much more complicated slide, which is mast cell mediated angioedema. So many mediators, but we're not going to talk about it. We're only going to talk about HAE. This is bradykinin. And if you think it like a war, like, a war of mast cell mediated angioedema and a war of bradykinin mediated angioedema. In bradykinin mediated angioedema, there is one weapon, while there are several weapons in the other side, in the mast cell mediated angioedema. So this is the mediator. This is the mediator in HAE. And where does it come from? So everything starts from factor 12, which is activated by contact activation. Now, how it activates in patient with HAE, we don't know. Some stress, some trigger, something activates factor 12 to become activated factor 12, which subsequently activates pre-kallikrein to kallikrein, and then kallikrein converts high molecular weight kininogen to bradykinin. Now, this is a physiological process. What happens in patient with HAE? Now, I'm going to show you how the protein which is deficient in patient with HAE, which is C1 inhibitor protein, controls the production of bradykinin at so many steps. C1 inhibitor protein, which is deficient in these patients, controls the production of bradykinin. If C1 inhibitor protein is gone, your bradykinin production goes up like anything. And then this bradykinin drives angioedema in these patients. So this is the pathophysiology, as simple as possible. This is a much more simplified form of saying this. So this is factor 12, which gets activated. It activates prekallikrein, and then prekallikrein or kallikrein activates high molecular weight kininogen to bradykinin, and this drives angioedema. I also want you to note here, this is the ACE enzyme. ACE enzyme is important in breaking down bradykinin to its products. So if you're using ACE inhibitor, then the bradykinin level goes up, and these patients develop angioedema. So ACE inhibitor induced angioedema. This is the likely pathophysiology of ACE inhibitor induced angioedema. Okay, so there are three conventional types of hereditary angioedema. Type 1, wherein the C1 inhibitor protein is deficient. Type 2, wherein the C1 inhibitor protein is normal in concentration, but its function is abnormal, and it constitutes about 15%. Type 3, which we used to call it as type 3, this terminology has now been removed, and this type 3 has now been labeled into various different types. So whether there is a defect in the factor 12 gene, plasminogen gene, kininogen gene. So we're not going to talk about these. These are rare types. We haven't seen even a single case of any of these defects in India so far. But yes, I mean, theoretically, you should know that there are several other types of HAE, which are caused by different genetic forms. They are different clinically from the most common form of HAE, which is caused by this SERPING1 gene defect, leading to deficiency of the C1 inhibitor protein. Okay. So in my next few slides, I'll be talking about the epidemiology and the current state of this disease in India. So this is what we did a few months ago, and we looked at some of the states in India, and we looked at the epidemiology of this disease from some of the states in India. So this is Chandigarh, and I want to focus you on this particular state, which is Jammu. So this is a district in Jammu, which is known as Riyasi district. So we have been able to identify approximately 12 patients of HAE from Chandigarh, and if you calculate the prevalence of HAE in Chandigarh based on these, prevalence is about 0.49 per 50,000. This I'll talk about this family or this population later. We have been able to identify more than 41 patients. Why I said more than 41? Because we have been able to identify 41, but we know that there are at least 60-70 patients in this particular area, and we have not yet been able to screen all of them. If you take this population of this particular district and the number of patients that have been identified from this area, the prevalence comes out to be about 5 per 50,000, very high. If you take the global prevalence, we don't have nationwide prevalence data from India, but if you take global prevalence of this disease, which is 1 in 50,000, 1 in 10,000 to 1 in 50,000, if you extrapolate to our population, we're likely to have 27,000 to 135,000 patients with this disease in India at present. But to the best of our knowledge, we've not yet been able to diagnose these patients. We're lacking in diagnosing these patients to a large extent. Because I'm sitting in Bangalore, I'm standing in Karnataka, I want to talk about what is the prevalence of this disease, what is the likely number of patients with disease in Bangalore and Karnataka. About 272 to 1,360 patients only in Bangalore. And if you talk about Karnataka, 1,434 to 7,171 patients in entire Karnataka. So, to the best of my knowledge, in the entire Bangalore, I think not more than 50 patients have been diagnosed with this disease. So we are grossly lacking in diagnosing these patients, and this is alarming. We need to diagnose these patients. I don't know what these patients are going through, what these patients are being treated as. I'll talk about this briefly. So this story started with one patient who came to us like 2.5 years ago, and she reported that, oh, doctor, this disease is very, very common in our area. We were like, how can a rare disease be so common in our area? So we went to this particular area twice, those patients, and this was our second visit, wherein we actually called those patients to a medical college and asked them to meet the doctors there, because there was a big gap in the sense that patients felt that there is no doctor to see us, and the doctors felt that there is no patient with this disease in our region. And this was one CME that we organized in Jammu. And this is what we found. This is just a family, 26 patients affected in this family. Just one family, there are 26 patients affected in this family. And this is the kind of picture that we have in India, and a couple of deaths because of HAE in this family. I think what these patients are going through, they're dying. And this is a little bit of experience with mortality in these patients. So this, we've seen only one death with HAE who was on follow-up, who was taking treatment, who was diagnosed well in time. So this girl came from Jharkhand, and she could not access treatment that is needed at the time of laryngeal edema. She was requiring fresh frozen plasma at that time. So this was 2020. Now we have better treatment options available, and I'll talk about these when we talk about the treatment of this disease. But she died on way to the hospital. So it was one death we have encountered. But when we analyze the families that we have seen so far in Chandigarh, this is what is happening to these patients. We had 16 families who report death of at least one family member because of HAE. It was retrospective. So they came to us for their diagnosis, and then they said, okay, in our family, these many family members have died because of laryngeal edema. And this is what we found. So these 16 families reported approximately 35 deaths because of HAE. And this is just tip of the iceberg. I think there are many, many people who are still dying because of this disease because they are not diagnosed. And when we try to evaluate why these families lost patients because of laryngeal edema, so we compared families who reported mortality versus families who did not report mortality. And we found that there are no real factors that is causing death in these families. It's just lack of diagnosis. It's just delays in diagnosis and accessing the treatment. And this is what we observed in this analysis. So I think this is my last slide. I just wish to conclude by saying that HAE is characterized by recurrent episodes of non-itchy swelling. So no urticaria, no itching. If you have angioedema, do think of HAE. Urticaria is not a feature, and as you've seen, it remains undiagnosed for several, not years, but several decades sometimes. And laryngeal edema is a potentially life-threatening manifestation in HAE. With this, I wish to conclude my presentation, and thank you very much. I'm happy to take any questions.
For a very good introduction for the classification of hereditary angioedema. If we have any questions from the audience.
Sir. 2-year-old, sir.
Nothing less than 2 years old.
No,
It's reported in literature as such.
yeah. So this disease has been known to manifest during the neonatal life. So there are a couple of reports who have reported erythema marginatum neonatal life as a first symptom of hereditary angioedema. And it's very peculiar in children actually. So we haven't seen so far, but what I've read from the literature that in children they start having erythema marginatum. For a couple of years, they continue to have frequent episodes of erythema marginatum, and then they start developing angioedema. So if you have a patient who is coming with erythema marginatum like symptoms again and again, do think that this patient is likely to develop
Because it becomes difficult for us to actually distinguish pruritus in younger children. So they may just present with irritability, some rash, some cutaneous edema. We see a lot of children with that syndrome complex. So how do we proceed it? When do we refer it to an immunologist for further workup?
Right, sir. So you don't have to refer each and every case of angioedema to an immunologist or any expert for that matter. You just have to see based on those criteria that I showed, whether it's more like mast cell mediator or more like bradycardia mediated, and a very simple test which Dr. Sendhil is going to talk about in his presentation when we talk about the diagnosis of this disease. Do a C4 level. And C4 level is about 80 to 85% sensitive. It's not 100% sensitive. It's about 80 to 85% sensitive. If you have a low C4 level, if you have a presentation with angioedema, then this is nothing but hereditary angioedema. It's a very simple, easily available screening. It's complements C4 levels. Thank you.
Any other questions?
They wanted to know the cost of the test.
So C4 level is very easy. I mean, C4 level costs around in PGI it costs about 50 rupees. I think the commercial labs they cost about 200 million. I think it goes on 300 to 400. 180 in SRL labs. It's very cheap. It's very cheap. On the other hand, the other test which is done for diagnosing is C1 inhibitor levels. And that
Bangalore SRL? Bangalore SRL? Chandigarh SRL. CBC is only 650 rupees. With PS names, it becomes 1,000 rupees.
Yeah,
In a corporate level.
I'm just teaching that basically CBC would be around 400 to 500 each one. I'm saying.
In Bangalore.
In Bangalore. I'm from Astra CMI of here. So I work in the private sector. So yes, but the C1 inhibitor levels and the function would be a bit costlier. Especially I think the functional assay is not easily available and is also costly. Whereas C4, I think, is manageable, and we really see these patients and the amount of sucking they have. I don't think ordering of C4 would be very difficult in most of these patients. Yeah.
Thank you, Dr. Uncle. So I guess a lot more of us will be on the outlook for the symptoms of HAE.
Both, and probably will consider a simple C4 test, which may be rupees 500 or so, but much less as compared to the life that we can save.
Yeah.
So thank you.
Thank you.
Now, we move on to the next session, which is on diagnostic evaluation of a patient suspected to have hereditary angioedema. And for this, I would like to invite Dr. Major General A.K. Jaiswal to chair this session. Dr. A.K. Jaiswal is a senior consultant, former professor and HOD at AFMC Pune and BRAMC Bangalore. He has also received various prestigious awards, including the IADVL Lifetime Achievement Award, the legendary Dermatologist Award, the Best Teacher, and the J.C. Schroll Memorial Award.
Well, friends, good morning and welcome to this very important session of this prestigious CME. A CME which I believe has been specially organized to focus on a very, very rare disease, as rightly said by the other previous speakers, a disease, hereditary angioedema, a rare autosomal dominant disease with the incidence of, as mentioned, 1 in 50,000. In fact, to tell you frankly, ladies and gentlemen, during my 50 years, more than 50 years of active practice, 40 years in the armed forces, and then later on 10 years in the civil, I don't think I have ever come across a case of hereditary angioedema. Maybe many years, faint memories were not case, but I don't think so. Probably हो सकता है कि diagnosis वगैरह miss हुआ over that time. And hence I am very happy, lucky and keen that I am part of this prestigious CME, which has been jointly organized by 3 important societies like Hereditary Angioedema Society, Esther CMI, and of course our own Bangalore Dermatological Society. And for this and much more, my grateful thanks to Dr. Sunil Dogra, Dr. Ankur, Dr. Sagar for giving me this opportunity and honor to chair this session, and especially to honor our next speaker who's going to talk upon the evaluation of hereditary angioedema. Dr. Sandel, as you know all, that he is a professor, eminent dermatologist. He did his MBBS from BMC and then later on all his post-graduation from PJ Chandigarh. Now, so we are very happy and honored to be here, have you here, and we are eagerly waiting to listen to you.
Thank you very much, sir. Thank you very much for this kind introduction. Very nice to see quite a filled hall on a Sunday morning, especially cold Sunday morning. No one wants to venture out of the house. And taking up from Ankur, like he did ask how many of you have an actively following up case of HAE, and I did see a few hands going up. I would, before jumping into my talk, let me ask, like, how did you guys actually diagnose this case? Sorry, I didn't look back. Which are the hands which went up? Who are HAE cases? Who all are having it, following up with them? Yeah. Yes, madam. So how did you diagnose that case when it came to you? You can sit down, ma'am, please. Okay. Okay, so that was lately. Where how many months back or how many years back did you see a case like that? Right, fine. Because as Ankur said, the incidence, what we know, or the prevalence of hereditary angioedema, what we know in the Western literature is 1 in 50,000. In India, the prevalence is unknown. In India, the prevalence is unknown. So hopefully we get more and more cases and thing, or probably it is just going under our nose, which we, like how Ankur said, like the patients usually present to us when the angioedema is settling or alone, right? And we want something to come down as immediately as possible. So that's what's happening, and it goes things like that. So let's go into the top. So the first and foremost, when to suspect a case of HAE. So history of recurrent swelling in the skin. So whether it's in the extremity space or genitals, the presence of more internal organ involvement, especially gastrointestinal pain and cramps, and along with laryngeal edema. So this can also be present in an mast cell mediated angioedema, but only thing is mast cell mediated angioedema usually has one or two wheels along with it, so that it will help us in catching the case of this one. But there are cases of mast cell mediated angioedema without any wheels also, but there the symptoms are itching. Here the symptoms are not there. The patient maximum will have some sort of a pricking sensation or a heaviness because of the angioedema proper. So these are the other things which will help you to further strengthen it. That is a positive family history, the onset of symptoms in the childhood and adolescence. So recurrent painful abdominal symptoms, occurrence of upper airway edema, failure to respond to antihistamines. This is very common. Whenever you find a patient of angioedema who is not coming down, if you're one who's passing, managing the urticaria patients or angioedema on basis of EACI guidelines, you increase the dose of antihistamine to 4 times the level. Still you feel the patient is not coming down in his symptomatology or a giving Visalon, not getting that amount of improvement which you are supposed to expect, please suspect HAE. And then presence of a prodrome, like just like a epilepsy patient, the patients will have some sort of a prodrome coming up, especially one who is experienced in having this wheels. And of course, absence of wheels will help you in diagnosing of HAE. So this is the most simplified picture from Ankur, whatever I got. We know the C1 esterase inhibitor inhibits both factor 12A as well as the calcium formation, thereby preventing the excess formation of bradykinin. So when bradykinin becomes excessively produced with the action on the bradykinin B2 receptors, which is present on the vessel wall, brings about the catastrophic manifestations of HAE. So this fellow is very important to modulate his action. And in normal individual, what happens whenever the bradykinin is formed, the ACE inhibitors is there to catch it immediately and quench it and make use of it, thereby preventing the events of HAE coming in. So coming to my talk, the diagnosis of HAE. So first thing what we do is required is the measurement of the serum or the plasma levels of C1 inhibitory function, this is C1 INH protein levels as well as the C4 levels. All three needs to be done whether if you want to make a diagnosis of HAE 1 or 2. By combining all these three tests, the studies have shown that it increases the diagnostic accuracy is very high, and it's higher than if any of these tests which is used alone. And C4 is usually low in patients with this hereditary angioedema 1 or 2. And however, the sensitivity and specificity of using C4 alone is very low. Why means sometimes the might be there. But of course, if the C4 level estimation is done when the patient is having an active angioedema episode, then the sensitivity of this goes up. So usually it is the only parameter to diagnose HAE is not one parameter is not thing accepted for diagnosis of HAE. So this is one of the study which from the society we had published recently as an international study in Asia Pacific Journal on the management of hereditary angioedema, where we did give a simplified version how to diagnose HAE very easy and the management approach in resource poor conditions like our country. So let's see the algorithm. So when we have a suspected case hereditary angioedema which is sitting with us, the first and foremost, like what madam said, we will do the C4 levels, which is very easily available in all the probably most of the hospitals will have this in their lab and everything. And the we have to do it by the nephelometry method, where the sensitivity increased or the effectivity of the C4 level estimation is very high. So let's divide it into two scenarios, one where the C4 levels are low, another where it's not high. So let's see the low part now. Now, once the C4 levels are low, it merely confirms the diagnosis of hereditary angioedema. So once we have done with it, now we go ahead and confirm it. We do the C1 esterase inhibitory levels. Now, if that is also low, it clinches our diagnosis of hereditary angioedema, or it can be acquired C1. Now, how to differentiate whether if it is HAE or an acquired part is, these are the things. So, acquired comes on the back disorders. Autoimmunity means SLE, and we all know usually SLE does not come with angioedema, although it is not clinically defined. The angioedema will have the rash and things. correlate with the findings. And then when the onset of angioedema is later in the life, especially after the third or the fourth decade, suspect an acquired cause, not a hereditary cause. And in patients with acquired angioedema caused by autoimmune disease, clinical manifestation, as I said already, and if it is SLV, the C1q levels may also be low. So that will also help in diagnosis. Somebody problem with it, right? I'll use the mic. Mic. Yeah. Okay, so that's the thing. Now coming to the thing. Now, if the C1 INH levels are normal or high, it might be the type 2 type of HAE. Now, how to prove it if it's a type 2 type of HAE? We go ahead and next to this one. That is the functional assessment. The functional assessment usually done by the ELISA method in order to see whether we can classify the patient as HAE. That is, we have a suspected patient who is giving you a good positive family history, probably at the early age of onset. You did the C4 levels, that is showing a low levels, and once C4 levels are low, then you confirmed it with the C1 INH thing levels. Then the esterase levels, if it is low, it tells you it is HAE or an acquired. Acquired means go back and correlate in the history, later onset, presence of other autoimmunity over there, move of HAE over there, or if it is present, it confirms a diagnosis of type 1. Now, even if it is, if the levels of esterase inhibitor levels are normal and the function is off, it diagnosis of HAE2 is. Now, next one. Next scenario is if the C4 levels is normal or high. The C4 is approximately, as I said, it is 80% sensitive and maybe normal in up to 20% of the classically diagnosed cases of HAE 1 and 2. So that's what I said. So using a single parameter is not enough in diagnosing HAE 1 or 2. And the sensitivity of C4 may increase when performed during an active episode of angioedema. And a normal C4 and a low C1 esterase inhibitor levels should always raise a suspicion of sampling handling error, and it should be repeated as testing is advised. Now, when the C1 esterase inhibitor levels are low, so the diagnosis can be type 1 or the acquired type of deficiency. Now, if it is normal, the type 2. Now, if the deficiency, it can be type 2 or the or normal type of C1 esterase inhibitor angioedema or a drug induced angioedema. Now, in this case, whenever we are confused, the genetic testing for the index case may be used for the diagnosis in the absence of access to the testing of C1 inhibitor INH levels can be done. So coming back again, so diagnosis for everything, the test results that point to HAE 1 and 2 should be confirmed. That is, testing should be repeated ideally in a certified laboratory. This recommendation is with respect to the diagnosis of HAE only. That is the reconfirmation. And there is no recommendation to be repeat the test once the diagnosis has already been established. So coming to the neonates, as we I think there are reports of the HAE present in the neonates also, as per your question. So the inheritance we know it is autosomal dominant. So we expect nearly 50% of the newborn to be affected with this chance of inheriting the disease. And the newborns with a positive family history are considered potentially affected unless it is excluded. And it must be well observed and tested as early as possible. And complement levels measured, it has been shown that complement levels measured in the umbilical cord blood of the full term neonates and as well as the are lower than the maternal levels, and the antigen and the functional C1 INH levels correspond to the 70% and 62% of adult values respectively. So therefore, testing for the same in the umbilical cord blood would produce false positive low results. So generally we directly test from the blood of the neonates itself. Any doubts still here? Pardon, ma'am? See, the thing is like for the case reports of erythema marginatum or some sort of a thing, the exact angioedema, the swelling is not being reported. That is one thing. There are only few case reports. Either I was too fast, everything went over the head, or it's fine. Yeah. Yeah, let's go ahead.
So, in neonates, other way of thinking of diagnosing is the parent has disease, they would want to know whether their child, when it's born, has a disease. And then it becomes a little difficult, as I said, that in neonates, it's so easy to test the population. Right? So, better way of doing it is genetic testing.
Genetic testing and this. So because like prenatally also, like before ahead also, if you want to confirm whether the person will have a thing, it's not sensitive because only 10% of the cases are usually found. So C1 INH antigenic and function levels are low in children. That is diagnosis of HAE in children is a thing, especially less than 1 year old with HAE 1 and 2. So the measurement of C4 was found not to be useful for diagnosing these two conditions in children below the age of 12 months, that is 1 year. And the genetic testing increases the diagnostic reliability in children and may be helpful with the genetic mutations, okay, of the parent is known. And all early complement testing performed in offspring of HAE 1 and 2 patients should be repeated after the age of 1 year. These are the recommendations. So in children with angioedema without wheals, the following must be tested. That is all three. That is the INH protein levels, the functionality, as well as the C4 levels. So in prenatal, the prenatal diagnosis is not common in clinical practice. Reasons include the mutations in the affected parent C1 INH gene are not detected in up to 10% of the cases, and identical mutations may be associated with substantially different phenotypes. And in developed countries, advances in therapy has been there significantly, thus helping the improved quality of life of these affected patients. So summarizing the diagnostic evaluation as given by the EACI group, that is European Association of Clinical and Allergic and Immunology. So whenever you suspect a case of hereditary angioedema, we get all these three tests done. That is C1 INH levels, the functionality, as well as the C4 levels. So we get these three scenarios. When all the three is low, it's either HAE1 or acquired angioedema 1. If it is HAE1, confirmed by repeated blood test, and when the family history is negative or onset or later in life, as I said, it is acquired angioedema. Coming to the second scenario, when the functionality is low but the levels are normal, HAE2 is confirmed again by the blood test. And the third one, that is when function is normal, the INH level is normal as well as C4 normal. There are two scenarios over there, but wherever the family history is positive, you still feel the patient will have a hereditary angioedema, then it can be something called as the HAE normal level sort of C1 INH, which Dr. Ankur said, which has all that angio normal angio did rare varieties, which he was able to calculating gene and things like that, which I have not seen. And if the family history is negative and no mutation causes is there, then it is a mast cell mediated angioedema. So this is the timeline of genetic diagnosis at our center. The way back in earliest report was somewhere in 1989 or 1990 when we reported the first case, and then this is how we have evolved from 2018. The Sanger sequencing of 8 exon SERPING1 gene. SERPING1 is serine protease inhibitor gene. That is what SERPING1 gene it is. Okay. Then we start using the WS and the targeted NGS, and finally now we are doing with the most advanced technologies. And this is one, the Sanger sequencing technique. Can show here, this is what is the difference which comes here when you come to India. Okay. The electrophotogram representing the frame shift in the point mutation respectively. And this is the next generation NGS, that is the next generation sequencing, which shows the visualization of variant using integrative genomic viewer. These are the different genes which have been studied. Then lately the multiplex litigation dependent probe and amplification, where the probe ratio of test sample normalized to reference. I acknowledge Dr. Dogra, Dr. Ankur, and Dr. Vinay in helping me in making the slides. Any questions? Yeah. Hmm. See, the problem is like when you have the parent who is carrying the gene, we know it is autosomal dominant. We have to say it is 50% chances that you're going to get. Now, since there might not be identicality and the variability you said, we can only say with the advanced treatment, whatever we have, or you do the genetic testing in the child itself and try to see which is the specific one, which then ultimately the management comes up to the 3-4 things, whatever we have. We have to counsel the parents that come, these are the symptomatology, these are the things, and come to us as soon as possible so that it can be taken care of properly.
Question, yeah.
Yes, Divya. See if you see the first thing is ANA. See, when we are doing when you're trying to see ANA is usually we do it in case of mast cell mediated angioedema. Here it does not have a thing. If you find it is a chronic refractory urticaria with an angioedema, then we try to do and this one. Or you want to see the C3, C4 levels you have done. You see the C4 levels are low. You want to compound it, you can do the ANA levels. But when you see the guidelines, we do not recommend it. That's one thing I think. And second question, sorry, I forgot. The genetic test usually in children. Like for example, in the newborn, where my madam was asking that when will you stress? For example, if any marginatum or if you want to have a suspicion the child might be having, then genetic is more better because there is a discordance in the C4 levels and the C1 levels between the mother and the child, and it cannot be done in the umbilical cord and things like that. Better to do a genetic testing there. To if you have a sanga, you get it, or if you want to be more advanced thing, much better it is. Yes, ma'am. Ma'am, that's what. See, SLE, if once you know it's an SLE and the angioedema, we know it's an associated feature. So we need not go. We can do a C4 level that itself says it can be low in case of SLE positive patients. Like it comes the other way around. The SLE is not yet come, but the child comes to you with an angioedema. Get a C4 levels and you feel it is low. What to do next? Whether you're missing out, you're waiting for the SLE features to come, or you're missing out on HAE, then you can do the levels and inhibitor levels and functionality and get the data. Yeah. Yes, C3, C4 level, these two things, C4 to low. Yeah. No, generally what happens because we are being a UCAT center also, in case of refractory urticaria, when patients also present with angioedema, where I think most of the time, like if I suspect, I usually refer off to Ankur because he takes care of, he is having a large follow-up case, so I refer it to him so that let him have the headache of it. If it is the mast cell mediated one, I usually get an ANA done and try to see where I will land.
Well, I think there will be no end to the questions.
So that's not a problem.
The success of any presentation is assessed by the amount of discussion it generates. So you can imagine. So, ladies and gentlemen, please give a good hand to him. He was a wonderful lucid talk. Thank you, Anko, for giving me this opportunity. God bless. Thank you.
Thank you, Professor Senthil. We shall now pause for a short tea break of 10 minutes.
request all the participants to gather for the next session, please. We request all the participants to gather for the next session, please. Hello. So we have Dr. Chetan Ginigiri who wants to make an announcement.
So good morning, everyone. I'm Dr. Chetan. I head the Department of Pediatrics at CME Hospital. This announcement is not related to the Hereditary Angioedema program that's going on, but we are hosting our second IAP Pediatric Emergency Medicine Chapter National Conference, and this is happening in Bangalore on February 29th and March 1st are the workshops, and March 2nd and 3rd is the main conference which is going to happen. So, as you know, IAP Pediatric Emergency Medicine Chapter is a newer chapter, and it is an offshoot of the Pediatric Intensive Care Chapter because pediatric emergency as a specialty itself is growing, and there is a huge need for people to understand the nuances of pediatric emergency as such. The general impression is that in post-graduation, 2 years out of 3 years, you do only emergencies most of the times, or pediatric acute care. So, and then the specialty of pediatric ICU has kind of taken off, and pediatric emergency and also the extension of pediatric emergency out of hospital into the community for creating awareness of a lot of things is the platform which we want to stabilize and grow. So all of you here who are pediatricians, if you can raise your hands, we'll kind of distribute the hard copies of the invites here. And please block those dates, and most welcome to this edition of Pediatric Emergency National Conference. It's going to be, we are expecting close to 500 to 600 delegates, around 100 faculty, 20 international faculty, and the talks range from anything and everything in pediatric emergencies as such. So thank you so much. I have with me Dr. Gunda, who is the organizing secretary of the Pediatric Emergency Medicine Conference Committee as such.
So I just want the pediatric faculty or pediatric, yeah, I'll just come in. So to join us for this conference, it will be something, of pediatric emergency. So we are making a lot of new things, more practical, more sitting in the clinic, sitting in the residents mainly, because especially emergency, there is very less of consultant driven. First on call is the resident. It can be casualty doctor, the pediatric resident. Usually the first year, initial months they post there, right? Assuming they know everything. But then when the sick child comes there, the parents hand over the child. You should be knowing the responsibility with which and the time constraint you have. So the more structured thoughts you have, more structured flow, right? Not doing things which are not supposed to be done, and doing the right things. I think that's what matters, the approach. So all this we're going to discuss. So please do join us for this emergency conference. It is really life-saving. I know like all other specialties save lives definitely, but it is really life-saving at that moment. And then you have that satisfaction, and high adrenaline is what keeps you going, right? Thank you very much. I'll just come in.
Thank you. Now, next on our agenda is an interesting case-based session to differentiate histamine-mediated and bradykinin-mediated angioedema. For this, I invite Dr. Chetan to chair this session. Dr. Chetan is a consultant in the Department of Pediatrics, CME, Bangalore. He is also the program director of the Pediatric Global Center of Excellence at Aster Bangalore.
Thank you, and I hope all of you had a great tea break as such. So during our time of pediatric training, pediatric allergy immunology was one department which was kind of very difficult to understand for us as postgraduates. And in PGI, when the pediatric allergy immunology department is so big,
And when our consultants used to see two different kinds of rashes and diagnose them, or very similar appearing rashes and diagnose different diseases for the same kind of rashes, we used to think that, we don't know what allergy immunology is. Is it a science? Is it a pseudoscience? But then 20 years since, I think the specialty has grown significantly, both in terms of its clinical approach and also in terms of the laboratory backup support which is available now, and also the development of specialties like genetics. We are able to really pinpoint these diseases with much more clarity and much more consistency. So Dr. Sagar needs no introduction. He's the first DM pediatric allergy immunology in the country. And he has been kind enough to join the team of Aster when he relocated to the city of Bangalore. And apart from being a great clinician, he's also an author who has authored a book on primary immunodeficiencies made simple. And the academic achievements speak for himself. We are really privileged to have him today discuss the clinical based scenarios on hereditary angioedema. So over to you, Sagar.
Thank you. Am I audible? Yeah. So once again, welcome. It's really wonderful to see on a Sunday morning. I must say crossing 50 number is like a dream come true when you arrange a single topic meeting. And I'm sure Dr. Ankur would also be happy with this. So the topic that I've been assigned is how does one differentiate histamine and bradykinin mediated angioedema? And I promise you I'll keep it case-based. We are clinicians and we love clinics. Complicated labs, pathomechanisms are good to read, but when it comes to practice, often we feel like not in there. But I'll get you there. Yeah. So angioedema. Now what is angioedema? It's non-pitting edema that involves subcutaneous tissue or submucosal layers of the tissue, and it can affect the face, the lips, the neck and the extremities, sometimes the oral cavity, the larynx that we have been talking since the morning, and sometimes the gut. What is important is that it becomes life-threatening when it involves the larynx, whatever is the cause. But if there is a laryngeal edema, we can understand it will cause asphyxiation and death. And intestinal angioedema, which is not so common but is painful. We often don't talk of pain here. For example, a lip swelling, a tongue swelling is not painful, but when it affects intestines, it is painful and it presents as acute abdomen. And Dr. Ankur has well highlighted in the very first talk that sometimes this can lead to surgeries which are not warranted. Now the topic that I've taken is to differentiate two, but I'll just begin with some basics. This has been dealt. Acquired angioedema, as the name suggests, is acquired. So it is not genetic in origin. Allergic is something that we all have seen. I'm sure in this hall, every practitioner has seen an allergic angioedema, or at least a child or a patient with allergy. And it is histamine mediated predominantly. Then there is something called non-histamine mediated, drug induced, which I think Dr. Ankur said is predominantly limited to the adult population. We will not touch upon it. But theoretically speaking, yes, ACE inhibitors are there. And then our own C1 esterase inhibitor. Now let me tell you, complement pathway or complement proteins in our body is an important component of our immune system, and it is fantastically regulated. On one end, where the complement gets activated, it takes care of infections. But an activated complement system must be regulated, and that is where comes our C1 inhibitor. It regulates this complement system and prevents unnecessary formation of bradykinin. So if that goes unregulated because of a deficiency, you are getting a lot of bradykinin in the tissue and you are getting a bradykinin mediated edema. If it is genetic in nature, we called it hereditary angioedema. If it was acquired in nature, we called it acquired angioedema because of C1 inhibitor deficiency. A classical example for acquired angioedema is SLE. So if a patient with lupus comes with angioedema, if I do a C3, C4, often it's low. If C1 inhibitor is checked and if it is low, I know it is acquired. But when I treat this patient with steroids, the C1 inhibitor levels will improve because it is an auto-antibody mediated deficiency that has happened. But if it is hereditary, the name suggests for itself, you cannot correct it by giving medications. You are going to treat the symptoms. Now, It goes beyond saying that allergic angioedema is way more commoner than hereditary angioedema. And that is why when a patient comes to our OPD with a lip swelling, tongue swelling, what is the immediate reaction? What is the reflex? Let's give him antihistaminics. Atarax, Allegra, whatever comes to our mind, cetirizine, we'll be starting them sometimes without even a second thought. And if it looks scary, the next thing we do is add steroids. So I don't think this what I'm talking is not familiar to any one of you. A child coming with rash, sometimes an occasional swelling, you jumping and giving steroids plus or minus antihistaminics. There lies the problem, that hereditary angioedema is a small cluster that you see in a big cluster of angioedema, and that is why it is often misdiagnosed as allergy. I think most patients that I see of hereditary angioedema, although I don't have a great experience, but often they have been treated as allergy, and almost all of them have received antihistaminics and many of them have received steroids. However, unfortunately, these medications make no difference to these patients. But since these patients recover spontaneously in a couple of days or sometimes in 3 to 4 days, pediatricians or physicians tend to believe that our medications have worked. And that is where they don't get diagnosed. But where lies the problem? The problem is in this number, 30% mortality. Allergic angioedema, as Dr. Ankur was saying, hardly kills a patient. It's very rare to see a laryngeal edema leading to death. Sometimes allergic angioedema can cause anaphylaxis and hypotension, and that is what can become life-threatening. As such, laryngeal edema doesn't become life-threatening. And most often, even if a patient lands up in emergency with laryngeal edema, what will you do? Even without a second thought, you will give steroids. You will give adrenaline, right? And adrenaline will work in allergic angioedema, and that is how those patients are saved. On the other hand, unfortunately, if a hereditary angioedema lands up in an emergency, you will push adrenaline. You will push steroids. It will not help that patient and the patient will die. And that is one of those reasons I feel why there is such a high mortality in these patients, that even if they reach emergency, nobody would be giving them the right medication what they need. So let me go through, as promised, through a few cases, and let us see. These are all real life cases, not many, a few here. A 5-year-old boy who came with intermittent lip swelling for the past 2 to 3 months. So each episode of lip swelling would come, especially sometimes in the morning hours, and last for about 6 to 12 hours. And this lip swelling was quite troublesome. The parents had reached out to their pediatrician. And this was the swelling, as you can see. The lips were swollen, and naturally the had received treatment and had partly responded as well. So associated complaints. Now that's very important. This child also reported recurrent wheals, as you can see, these hives over the back, over the face and the trunk for the past 2 months. But this makes life easy, because the moment you have such wheals, you know this is urticaria, and the edema that you saw is angioedema. Urticaria plus angioedema, I think, makes for the diagnosis. So this child received cetirizine, hydroxyzine. There was immediate response. Now that is very interesting. When you give antihistaminics, you will all agree the response is brisk. Within a few hours, the rash disappears, the edema disappears. However, it does reappear when you stop the medicine. And this is what was happening to this patient. So angioedema plus urticaria, the diagnosis is allergic angioedema. And when the urticaria goes on for, call it the chronic spontaneous urticaria. Again, this is fairly common in clinical practice. Now, this patient was then given a long course of pexofenadine for almost 4 weeks, and then that caused complete resolution of wheals. One simple message I would like to give, I have senior dermatologists here, they can kind of correct me, that whenever you start seeing urticaria coming in practice, there is a need to give a longer course of antihistaminic. The short course of 3 to 5 days sometimes doesn't help them, but when you give them a 4 to 6 weeks, that kind of breaks that cycle, and that kind of prevents them coming back to emergencies again and again. That is one message. And the learning point here is that urticaria is one condition where you can see wheals or what we call hives, angioedema, and sometimes both. And chronic spontaneous urticaria is a term when we use when the urticaria lasts for more than 6 weeks, and most often the cause is unknown. I would also like to dive a message that many of our chronic spontaneous urticaria patients get unnecessary allergy testing. There is practically no role for any allergy testing in most of these patients, and some of these patients, the IgE levels are high. That can kind of corroborate with your diagnosis, but is not always essential. Let's go to the second case. which actually took a full circle round. Now, this girl had recurrent lip swelling for the past 3 years, but the swelling kind of lasted for a little longish, almost for 48 hours. And this was associated with slurring of speech and difficulty in breathing on almost 2 occasions. The triggers were not known. In fact, this patient landed with a medical college, and because there was kind of laryngeal involvement, they thought of hereditary angioedema, and this patient was investigated. C4 levels were done, which were normal. C1 esterase inhibitor levels were also normal, and the functional assay was normal. Now this patient was given a diagnosis of so-called hereditary angioedema type 3. And let me tell you, this patient went on to receive tranexamic acid for more than 2 years, stanzolol, and a few courses of even fresh frozen plasma. Because we know that in hereditary angioedema, when there is an acute attack, the drug of choice in resource constraints is a fresh frozen plasma, which can give you C1 inhibitor. So there used to be some response, but because of ongoing stanzolol, this girl developed hoarseness of voice. We know stanzolol is an anabolic steroid, and this girl started developing this side effect. And finally, when she came back to us 2 months back, she had these wheals over her, all over her body. And we are surprised to know this, that this child on reviewing had wheals all along the course of the disease, but never documented in a clinical setting. And for the family, because the tongue swelling, the lip swelling was so prominent, they would only report that. And the moment we saw this rash, we were now clear that the diagnosis wasn't appropriate. We revised our diagnosis, made a diagnosis of chronic spontaneous urticaria, put them on a long course of antihistaminics, and the girl is now doing relatively better. So the message here is that sometimes allergic angioedema can take a bit longer to resolve. As per text, it can sometimes go up to 48 hours. However, the response to antihistaminics most often is very good. And HAE3, as Dr. Ankur rightly pointed, is a very, very rare diagnosis. So for all practical purposes, what I learned is that for us, if C4 is normal, C1 inhibitor is normal, rethink about allergic angioedema rather than making a diagnosis of HAE3, because we practically don't have any patient at this moment in our country. Now let's go to the next case. This was actually a family which was brought from, I think, Iraq, if I'm right. And this boy had episodic eye swelling that would slowly progress over the next 2 days, and by the 3rd or 4th day, the eye swelling would disappear. And occasionally there was limb swelling as well, and the family had sought consults from several places. What was interesting was this picture. This is the father, and he had this grotesque looking lip swelling that would last for 3 to 4 days. And obviously, looking at this kind of revealed that there is something going on. It is genetic because both father and the child are affected. But then when we took a detailed family history, there were at least more than 10 family members who were affected. And as has been highlighted, this tree reflects that this is autosomal dominant in nature. And such strong family history should make you think of hereditary angioedema and should make you think against the diagnosis of allergic angioedema. And that is where we got the C3 and C4. The C3 was normal, but the C4 was low. And again, the C1 esterase inhibitor levels were very low. And that kind of confirmed the diagnosis of C1 esterase inhibitor deficiency. We could counsel this family that now we do have C1 inhibitor injections available. However, as an emergency, you always have the plasma fluid. So how is hereditary angioedema different from the commoner one, the allergic angioedema? Now this has been highlighted. Urticarial itchy rashes. Think of allergic angioedema, the rashes are absent. This kind of the allergic angioedema progresses quite fast in minutes to hours, but also resolves quickly, usually within 24 hours. This progresses slowly, the hereditary angioedema, and it also usually resolves quite slowly. Now, response is quite prompt to antihistaminics and steroids in the first group, whereas practically you don't see any response in the second group. Now, this is another interesting slide I got from one of those papers, wherein they compared again these two, the allergic angioedema, the histamine mediated, and the HAE, which is the bradykinin mediated. You can see both of them can have swelling of the lips and tongue. Urticaria and itching was seen only in the first group. Laryngeal swelling has been reported both sides. Facial swelling is kind of more common in hereditary angioedema. Abdominal pain, again, we can have it in allergic angioedema, but more common that side. You can see the rapidity and response to epinephrine this side. Nausea and vomiting somehow is more common, again, with histamine mediated angioedema as well. And one peculiar thing, hypotension and shock. So we hardly see in hereditary angioedema hypotension, sudden onset hypotension, which basically means anaphylaxis, which happens in allergic angioedema. And again, presence of V's, elevated IgE levels, those corroborative evidence will tell you that this patient is possibly having a allergic background. And genitourinary swelling, peripheral swelling is much more common in bradykinin mediated angioedema. Again, this interesting slide, I think this has been highlighted before, but you can see the rapidity of onset and the resolution. The first graph is for the histamine mediated. The second graph where the resolution is happening within 48 hours is the ACE inhibitor. And they say if you stop the drug within 48 hours, you should see a resolution of angioedema if it is ACE inhibitor related. And in hereditary angioedema, typically going on slowly, rising and reaching the peak by 24 to 36 hours and then resolving. So I think in the very first talk, Dr. Chetan was asking, how do you differentiate these two? So I think the very first thing is to sit down with the patient and take a good history. What is the onset? How is the progression? How is the resolution? And invariably, all these patients would have been given antihistaminics. How is the response? If you give an antihistaminic within few hours, is the child getting better? Answer is yes. You know it's possibly allergic. Answer is no. Then you go and start doing the testing, maybe to begin with the C4 levels. Now this is the last case, a 37-year-old gentleman who had recurrent lip swelling for several months and associated with choking episodes, so possibly laryngeal edema as well. Evaluation had shown low C4 levels and a very low C1 esterase inhibitor levels. So you now know the diagnosis. This is type 1 hereditary angioedema in an adult patient. This patient had been treated with tranexamic acid, danazol, and I remember this was 2 or 3 years back, wherein every month this patient would come to our emergency and we had no choice but to give a fresh frozen plasma because we didn't have the C1 inhibitor injection then. Unfortunately, this patient landed up with cerebral sinus venous thrombosis and he had to undergo a major surgery and then he recovered. Somehow after this, he hasn't had much attacks of hereditary angioedema. So I don't have answers for that. But then this was a major event in the life of this patient. He has recovered out of that. But the challenge that time was we did not have C1 inhibitor injection. So this patient is ventilated and there were a lot of discussion as to when you intubate this patient, will it trigger a laryngeal edema? A multidisciplinary team, and then could you give FFP in the presence of thrombosis? A lot of discussion and somehow this patient could sail through. So the learning points for us were that compared to general population, the HAE patients do have a slightly increased risk of venous thromboembolic events. And theoretically speaking, they say that the C1 esterase inhibitor not only inhibits this classical pathway, but it also inhibits the mannose-associated serine protease, MASP1. And when that is not inhibited, you get a very high level of MASP2, C3, C5 that can cause increased risk of VT. But this is all theory, but basically it means that some of these patients can have unusual complications. So this is one of those slides I think we all have discussed. As you can see, the trigger here is allergic, whereas in non-allergic, there may be no trigger, but I think I agree that minor trauma sometimes does trigger hereditary angioedema episodes. And typically the edema here is diffuse and symmetric, here it is focal. If I would like to compare other things, as you can see, there is no urticaria, but yes, we have spoken about the erythema marginatum. Anaphylaxis, yes, that means you are dealing with allergic angioedema. And usually it doesn't involve other organs, the hereditary angioedema, but can involve bowel. And as you can see, 100% would respond to antihistaminics, where here the response is not there. This is the last slide, just to make things simple. I know there are various types of angioedema, but for a practitioner like me, this is what I follow. If there is a clear angioedema, episodic swelling of limbs or face, ask for history of urticaria or a itchy rash. If it is present, then possibly you are dealing with allergic angioedema. Mostly Ig is high in these settings, maybe normal. You will have this patient responding to antihistaminics. The answer is no for urticaria. You have to now start questioning, is this hereditary angioedema? I think this is the most important step for diagnosis. The moment you strike this question, can this be hereditary angioedema, when you see an episodic lip swelling, tongue swelling, limb swelling, you have started the diagnosis. Because then you will get the C4 levels, as has been highlighted, at least in 80% cases it may be low. Then you can go for the inhibitor levels, the functions, and if that is low, you have clinched the diagnosis. And the therapy again would be discussed in detail in the next talk. But for me, I have often used FFPs, but today we have the luxury of using the injection C1 inhibitor. So with this, I would like to end my talk and thank Dr. Ankur and the whole team for giving this opportunity. Thank you. So are there any questions? Yeah, I think most patients with hereditary angioedema would have onset early in life, but that is not always the rule. They can sometimes present later in life. But I think Dr. Ankur can correct me, but literature-wise, most often they have a childhood onset, but sometimes they go undiagnosed. But I don't think if you have an adult onset, you should completely rule it out, but you should bring in differentials of acquired angioedema then. Like for example, possibilities of lupus, an autoimmune condition, or an underlying lymphoma. Those things will come to your mind if it is a very new onset, adult onset angioedema. But sometimes a good family history helps. That is what we have seen. Yeah. Yeah, so there are no specific triggers, but I think if there are patient organizations, they would tell. I have heard a few patients telling that they have their own identification for triggers. Some of them know that a trauma causes them, as I think Dr. Ankush talk was there, menstrual periods causes them. So there can be different triggers for different patients, and as the attacks go by, patients themselves get aware that this is possibly my trigger, or also they have those prodromal symptoms wherein they can recognize before a clinician recognizes. But I don't think there are very well defined triggers. You can universally say that this will cause angioedema in every patient. If there are more comments, I think, yeah. Yeah. Yeah.
Because pain needs more inflammation. So then you need to route some other cause, which is the cause for that. Because one is, if you see, localized means it comes to HAE only, but usually HAE is non-painful there in this thing. If it is only mucosa inside the GI tract or something, then you have that cramps pain, I think. Otherwise in skin, it is not painful.
So basically, pain is not a predominant symptom. If it is excruciatingly painful or erythematous, then we are possibly looking at a very different diagnosis. Yeah. You're talking about allergies, I think, ma'am, because you have given antihistaminics. Yeah. I think one of the common causes for urticaria in children is viral infections. So yeah, so possibly. So the message that we want to drive through this meeting is that there is a disease called hereditary angioedema. That's message number one. Message number two is when you are seeing angioedema, at least start making this differential diagnosis. There is a false belief that tests are not available. I would disagree. Tests are available. C1 inhibitor level is available. Even functional assays are available. I agree that there is a cost to it, but the tests are available. So if we think about them, we can definitely order this testing. And even these days, genetic testing is available. But I would not recommend a genetic test to begin with. Let's do baseline screening test and then we can proceed accordingly. There is intestinal mucosal edema that you see. Again, the mechanism is the same, but it is bradykinin mediated mucosal edema that causes intestinal pain. Yeah, this is non-inflammatory, but see, edema is because, to make it simple, edema is accumulation of tissue in the extracellular space. And here, inflammation is not driving it. It is bradykinin that is driving it. So when we say inflammation, there are inflammatory mediators that come to that milieu, possibly because of infection or injury. And that is our classical definition, rubor, tuber, calor. So that is nothing that we see here. We are only seeing the swelling here. So it's not inflammatory. I don't have answer. Maybe no. So we don't know. I at least I don't know. I don't think we have answers to that. For some reason that nobody knows why lungs are not affected, why breathing is not affected, why kidneys are not affected, why heart is not affected. So they are not affected. That lung is a potential site that can develop edema. So it surprises the initial researcher why lung is not getting that. I think Dr. Ankur will touch upon the therapy because he has a complete session on therapy. So, okay. So thank you once again, and I'll hand. Thank you. Thank you.
Thank you.
Trying to keep everyone awake.
Thank you, Dr. Sagar, for this informative and engaging session. Moving forward, our next session is an update on the management of hereditary angioedema. I now invite Dr. Sahana Devdas and Dr. Usha to chair this session. Dr. Sahana is a professor and chief neonatologist at Vanivilas Children's Hospital, Bangalore Medical College, and has more than 40 publications to her name. Dr. Usha is an associate professor at Sri Atal Bihari Vajpayee Medical College and Research Institute, Bangalore. She is also the NICU in charge and nodal officer of SNCU and has several publications to her name.
At the outset, I thank Dr. Sagar and the team for giving me this opportunity. Actually, it was a busy schedule. We have a Muscan quality assurance on Monday and Tuesday at our hospital because ours is the biggest hospital who delivers 1,500 per month, you know. So it was a busy schedule, but you put my name and it's an insight. I learned a lot about HAE. We had one child, an adolescent, because I'm being a professor at pediatric and that, we had one child with that. And then I took advice of Dr. Sagar, and even C1Q deficiency, he's taking care of them, my own patients. Dr. Sagar, I thank him and his team, and it is a big, great privilege to be here. Thank you. And I invite Dr. Ankur for this next talk.
Thank you, ma'am. Okay, I think it's good afternoon. First of all, I'm here again, and you'll have to bear me again for another 30 minutes. So this is a very special session. We are going to talk about management. A couple of things that I just wanted to clarify with this talk, that somebody asked about the genetic testing. Genetic testing is not mandatory at all for diagnosis of HAE. The diagnosis of HAE relies on C4 levels and at the max C1 inhibitor levels. It is not at all mandatory to do the genetic testing. So if you're in a position to do it like we do it, like we do it for all our patients. If you're not in a position to do it, don't feel bad about it. It is not at all required, right? So I'll go straight to my talk. Okay. Again, one thing to disclose, I have lots of questions for you for this session. So please ask me questions. Otherwise, I'll ask you questions at the end of my presentations. I'll talk briefly about principles of management because it is important. I'll show you that very complicated slide that I showed in my previous presentation. The principles of management, like which pathways are involved and which pathway do we need to target to control the disease. When we started seeing HAE, we started reading guidelines, we started reading ERT guidelines, you know, all kinds of guidelines. We realized, no, I mean, we can't use these guidelines in our settings. And then we decided last year to have our own consensus based on what is available with us, what we can use. And that's what I'm going to talk about in my presentation predominantly. And you don't have to really remember everything, just the basic points, because this guideline is available it's available with you right now. It's in the handout, it's in the, you know, it's being given to you in the form of a print, these guidelines or consensus, and you can easily go through them. So the management of HAE is on demand, short-term prophylaxis and long-term prophylaxis, and I'm going to talk about this thing in detail and how is it different from international guidelines. And then I'll be talking about the case scenario and I'll be asking you a lot of questions on that. So let's talk about the principles of management. This is again another the same complicated slide that I showed you. Starts with factor 12, activates it, something activates it that we don't know, and then factor 12 activates pre-kallikrein to form kallikrein, and then the bradykinin is formed. And this is C1 inhibitor. So principles are clear. The protein is deficient. The protein is deficient, which is C1 inhibitor protein. You replace it. As simple as that. And this treatment is now available with us. So you replace the C1 inhibitor protein, your disease is okay, your disease is better. But that's not a treatment, that's not a curative treatment, it's a symptomatic treatment, right? So that's one form of treatment. What is the other form of treatment? You know the culprits. You already know the culprits. Kallikrein is one culprit. You know, kallikrein is also activated. You inhibit kallikrein and your disease is kind of gone. Not gone, but controlled. So there are certain drugs that inhibits kallikrein, and these names are written here: ecallantide, lenalidomide. You don't have to remember these because these are not available in India, but you just have to remember because sometime, yes, these drugs will be available in India. So that's another principle. You inhibit kallikrein and you control your disease. You inhibit bradykinin, that's another culprit, and your disease is controlled. So there is this drug called icatibant. You can see it here. This drug is it's a very good drug. It's a very good drug for on-demand treatment. Your patient has an attack, and at that point of time, what is driving this attack? It's bradykinin. Bradykinin is like going in, so much of concentration in the blood. You inhibit it by giving icatibant. This drug is available in the form of subcutaneous injection. You give it, your disease is controlled. It's a wonderful drug for on-demand treatment, but unfortunately, again, not available in India. I mean, very unfortunate that this drug is being manufactured by one of the Indian companies, but not being marketed in India, but being marketed in many other countries. But I think it's just a matter of time when we'll have these drugs available in India as well. This is tranexamic acid. I think you heard it from several times from Dr. Sagar's talk that tranexamic acid is used for the management of angioedema, and it's a drug that we use for long-term prophylaxis, not for on-demand treatment. You don't use it when your patient has swelling. You use it to prevent the development of an attack. And where does it act? So this is plasminogen. I didn't talk about this previously. So this is plasminogen, converts to plasmin, and tranexamic acid. And this plasmin also has some role in the pathophysiology of HAE. And you inhibit this pathway using tranexamic acid, and it suppresses your symptoms. It doesn't allow too many symptoms to develop. So it is used as a long-term prophylaxis. So these are the principles. These are the various pathways involved in the pathogenesis of HAE. And that's how you inhibit and control your patient. Right. So what is on demand? On demand means you have a patient who comes with an attack. You treat that attack at that particular point of time. This is on demand treatment. Every single patient of HAE needs on demand treatment. Every single patient of HAE needs on demand treatment. Okay. And these are the drugs. So these are all the drugs that are available. The ones that are highlighted in yellow are the ones that are available in India. So we are not going to talk about any other drug. Plasma-derived C1 inhibitor concentrate, which is now available in India. It's a very good drug for on-demand treatment, and we'll talk about this. When this was not available, we were using fresh frozen plasma. And fresh frozen plasma has 1 unit of C1 inhibitor in 1 ml of it. So again, 10 to 20 ml per kg, and your attack gets controlled, right? We'll talk also about the differences between use of C1 inhibitor and fresh frozen plasma. Now, when do you use short-term prophylaxis? You know your patient, and you know this patient is going through some situation where she is likely to develop an acute attack. What did you tell me? Yeah, for example. So it's important to identify triggers. We talked about it. We didn't talk about it in detail, but it is important to identify triggers in patients with HAE are patient specific. Some patients have some triggers, and they are the trigger for that patient throughout their life. Some patients have no trigger at all, and they never have their trigger, never have any trigger for their attack. Some patients have some trigger, and that trigger is for that patient throughout their life. So it is important to identify triggers. So as just one mentioned, menstruation is a trigger. For some patients, it's a trigger that triggers their attack almost all the time. And then you can use a little bit of drug at that point of time to control the attack. What could be the other form of trigger? Stress. It's difficult to quantify stress actually, and it is difficult to use drug at that point of time. Trauma. Yes, trauma. Trauma is an important trigger. What forms of trauma? Like, so if the patient is undergoing surgery, it's a trauma. So that point of time, we have to be very, very careful, especially the surgery involving the oropharyngeal, endotracheal infection. So this is a trauma, and this patient is very, very high, has a very high likelihood of developing angioedema at that point of time. You have to be very, very careful. And then we use drugs, and then this form of treatment is short-term prophylaxis. We use it for a very, very short period when we know that there is a risk. And we'll talk about this in detail. And again, we have plasma-derived C1 inhibitor concentrate now that we've been using. Prior to this, we were using fresh frozen plasma and attenuated androgens. Now, long-term prophylaxis is something which is difficult. You have to decide which patient needs long-term prophylaxis, because if you start long-term prophylaxis, this has to be lifelong. You can't stop it. So you have to decide which patient actually need long-term prophylaxis. Honestly, when C1 inhibitor concentrate was not available with us, we had a very low threshold for initiating long-term prophylaxis in almost all patients, because we knew we don't have a very good on-demand treatment. And if this patient ends up developing a laryngeal edema, we may not be able to do much. So we used to give long-term prophylaxis to almost all patients, but now we kind of categorize. Okay, look, this patient has access to C1 inhibitor. Let's not give him long-term prophylaxis. He or she may do well just with on-demand treatment with C1 inhibitor because he or she has easy access to it. And then there are certain other criteria to decide whether this patient actually needs long-term prophylaxis or not. We don't talk about this. These are the drugs that can be used for long-term prophylaxis. Predominantly in India, we use attenuated androgens or tranexamic acid, or maybe a combination of the two. The plasma-derived C1 inhibitor concentrate that is available with us, we'll talk about it. It's an IV preparation, and if it has to be used for long-term prophylaxis, it has to be used every 3 days, which is not possible. So for long-term prophylaxis, we are not in a position to use plasma-derived C1 inhibitor concentrate because we don't have the subcutaneous preparation so far. But the attenuated androgens and tranexamic acid we've been using, and they tend to work very well in these patients. So these are the principles. One more principle that you should remember, and you should always tell your patient, you know this figure I showed you previously. This is the natural history of an untreated HAE attack, right? And if you want to hit your patient at this point of time, it's of no use. The swelling has already settled in. The swelling will disappear on its own. It will take its own time. So there is no use. If you have to hit your patient, this is the time. So if you want to use on-demand treatment, it must be used as soon as possible when the patient starts developing attack. So if you use it here, it will go like this. If you use it here, it will still follow this course. It is not going to make much difference. That doesn't mean that if your patient comes at that point of time, you don't use any treatment. You still use it. You still use it because you never know how is this patient going to behave, how is the swelling going to progress further, especially if it's a laryngeal edema. You can't take risk. You still have to use it. But yes, if you have a patient, you counsel them, use it as soon as possible, start develop swelling. That's the principle, right? Okay, so this is the consensus or guideline that I was talking about, which is available with you, and I'll be majorly focusing on this with little bit of experience that we have in managing these patients. So this is one consensus recommendation for acute attack. That means on-demand treatment. The treatment has to be individualized. I can't say that, okay, this is the prescription and just go and use it for all patients. It doesn't happen. It has to be individualized. Now, we have this intravenous plasma-derived C1 inhibitor concentrate, and that should ideally be used for all attacks, whether it is in the hands, whether it is on the face, whether it is on the legs, whether it is in the abdomen or genitalia, anywhere. But we are in resource-constrained settings. It's a costly drug. We can't use it for all attacks. It must be used for all attacks that involve the larynx or if it involves the abdomen. So that is what has been recommended in these guidelines, because these are fatal attacks. The abdominal attack can be associated with excruciating pain. I have heard patients saying, it's better I die rather than having an abdominal attack. It is so excruciating. So if your patient has a laryngeal attack, if your patient has a abdominal attack, then please use C1 inhibitor concentrate. And then so abdominal attacks, I think it's important to identify. The patient has to identify, yes, I am having an abdominal attack, because it could just be a pain of gastritis. But let me tell you, your patient will tell you better that no, this is not the pain of gastritis. This is the pain of an abdominal attack of HAE. And as I said, it must be used as soon as possible, preferably within 1 hour of symptom onset, and preferably through self-administration. And this is what we are now stressing on, that the plasma-derived C1 inhibitor concentrate, this treatment for on-demand treatment, should be available at home, should be used by the patient at home or at a very nearby healthcare facility. And I'll show you the reason why it must be used as soon as possible. In this recommendation, we mentioned that one should avoid using FFP. That doesn't mean that you should not use FFP. we wanted to discourage the use of FFP for reason that I'll mention in my subsequent slides, because FFP has its own problems, and I'm going to show you in my slides. But if nothing is available, if you don't have plasma-derived C1 inhibitor concentrate, if you can't access it, if you have an acute attack, please use fresh frozen plasma. It will still work. But try your best to get plasma-derived C1 inhibitor concentrate for your patients during an acute attack. Okay, so the recommended dose is 10 to 20 unit per kg. If you read international guidelines, they'll say no 20 unit per kg, no 10 to 20 unit per kg. But we know with little bit of experience that if you use this drug as soon as possible after the acute attack, even a lower dose will work. So what we do, we tend to use 10 unit per kg. If a patient has come very early in the attack, if the patient has peripheral attacks, we tend to use a lower dose. The injections come in a vial of 500 units, and then you have to decide whether you want to use one vial or two vials depending on the weight of the child or the patient. Now, if you have laryngeal attack, don't struggle with the doses. Use the highest possible dose, which is 20 units per kg. So that's what the recommendation is, right? The international guidelines just suggest that use 20 units per kg. There is no concept of using lower doses of this drug. On-demand treatment during a prodrome is not recommended because prodromes are largely subjective. There are objective prodromes, but they are largely subjective. So that is not recommended to be used during prodromes. And so, for example, if you have a patient whose weight is 10 kg and you want to use C1 inhibitor concentrate, the dose comes out to be either 100 unit if you use 10 or 200 unit if you want to use 20 unit per kg. So can somebody tell me what will you do? You have a 500 unit vial, you want to use 100 unit or 200 unit, what do you do with the rest of the 300 units? What do you do? Sorry? Discard? What will you do? Sorry? No, once it is open, you can't use it again. So give the highest, give the full vial. Give the full vial. It is a very wide therapeutic index. It is definitely not going to cause any harm. Do not discard any injection. Do not keep it in the fridge for next administration. Once it is open, use it. So if you want to use, for example, 800 unit and you have 500, use 1000 unit. If you want to use 200, 300, use 500 unit, right? So that's so this is what the last statement says. It has a very wide therapeutic index and no dosage should be discarded. Okay. So this is what has been our experience. So this is one child that we managed. This is 14-year-old child, and he came with this laryngeal edema. And look at the FFP transfusion that we gave. He was a well-built child, and we had to give him like almost continuous transfusion of FFP. This was a situation when we did not have availability of C1 inhibitor concentrate in India. But now what we do, we give them C1 inhibitor concentrate, and they are like a normal child in few minutes to few hours, depending on how early in the attack you use this drug. I want to tell you the differences between use of FFP and use of inhibitor concentrate. On the left, what happens? This is the practical problem we face almost not daily, but at least once in a week. So your patient has an acute episode. What is the next step if you want to use FFP? He has to go to a hospital. He has to go to the hospital. You can't give FFP at home. What is the time? It could be 2 to 6 hours. I'm sure you all know this monument. It was in news. And if something like this is on your way, this may be even 10 hours. That's the problem. What then? That hospital has to have access to blood bank, which not most, but many hospitals do not have. Once the patient reaches hospital, the doctor over there has to have the understanding of about HAE, that this is a laryngeal edema. He has to use FFP. He has to use FFP. He doesn't have to use corticosteroids, epinephrine, adrenaline. But most of these patients end up getting these for the first time, and nobody really thinks about giving FFP. Again, 2 to 6 hours at least. Sometime even more. Sometimes we have to call that emergency physician. Look, this is HAE, this is laryngeal edema. Please do not use steroid. Please give FFP. So look at the time that is consumed, and then a decision to give FFP is made, and the FFP is administered, which can take at least 4 to 6 hours. You send it to the blood bank, requisition, the blood comes. It takes time to come to a normal temperature, and then it is a problem. It takes about 4 to 6 hours. On the other hand, if you want to use C1 inhibitor concentrate, you have an acute episode, you use plasma derived C1 inhibitor concentrate either through self-administration or by a nearby healthcare facility. It takes about 15 to 30 minutes, only 15 to 30 minutes. So it's as simple as that and as practical as that. This is the practical problem between the use of FFP and between the use of C1 inhibitor concentrate. And that is what happened with one of the patients that I showed you in my first presentation. She just could not access FFP. She had a laryngeal edema. Parents took her to the hospital. She died on the way. If she had access to C1 inhibitor concentrate, she could have survived. So, I mean, again, the same thing. So this, I mean, this is not possible for FFP. This is just not possible for FFP. You end up using FFP only when the attack is into its final stages. This can never happen, almost never happen with use of fresh frozen plasma. What are the other challenges? Fresh frozen plasma undoubtedly is less effective than C1 inhibitor. It has a very, very slow effect, and it's a blood product. It's blood. It has its own side effects. Transfusion reactions, volume overload, all kinds of things. So you have to be careful with use of FFP. That doesn't mean that nowhere means that we are trying to discourage the use of FFP. FFP is still the best possible choice if you do not have access to C1 inhibitor concentrate. On the other hand, plasma derived C1 inhibitor concentrate is much more effective, very quick to add, and practically no side effects. If a patient uses it at home, it has no side effects. You just tell them, keep it at home. Either you use it yourself, give them a prescription, or ask your local physician to use it. It is very, very safe. We haven't seen any reaction to the use of C1 inhibitor concentrate. It has to be just given as a push. The only problem is cost. But we are trying to, there are some mechanisms to arrange, and we'll talk about this maybe in the next presentation. So this was about the on-demand treatment for an acute attack of HAE. Anything that you want to ask before I proceed? Any experience that you want to share? Because I'm coming up with questions in very soon. Yeah. So self-administration, it's a challenge, and that is what needs a little bit of training. And this is what we have been working on right now. I know of centers, not in India, but in other parts of the country, other parts of the world, wherein even a 12-year-old child has been self-trained to self-administer C1 inhibitor injection. So I think we can do it. We can definitely do it, but it is a matter of time. We just have to train these people for self-administration. Ma'am, there are subcutaneous preparations available. Subcutaneous is available. I think it will be available very soon, but as of now, it's not available. Yes. No, ma'am, it can't be. It can't be used subcutaneously. Okay. So we talked about short-term prophylaxis in brief. So when do you use short-term prophylaxis? In fact, what do you use for short-term prophylaxis? So intravenous plasma-derived C1 inhibitor concentrate is the drug of choice. What is the dose? 10 to 20 units per kg for children, or the maximum highest possible dose is 1000 or 1500. A lower dose may also work for short-term prophylaxis. So in our experience, we've actually used a lower dose. So in about 5 or 6 procedures that we observed with use of plasma-derived C1 inhibitor concentrate, use it just before the procedures. But you have to decide which procedures mandate use of plasma-derived C1 inhibitor concentrate. It should be used soon before the surgery, and subsequent doses may be decided on a case-to-case basis. So it is not necessary you have to repeat the dose after the surgery. It should be given just before surgery and then just wait for the surgery to happen. So the dictum is, for all minor procedures, RCT, root canal treatment, any minor procedure, you have to have a backup of plasma-derived C1 inhibitor concentrate. Where it must be used for dental procedures such as tooth extraction, for any endotracheal intubation, for endoscopy, for bronchoscopy, it must be used. You have to use. If a patient is undergoing dental extraction, please do not attempt dental extraction without giving the short-term prophylaxis. It is likely to cause laryngeal edema, and then you will be in a difficult situation. So we talked about menstruation as a trigger. We've seen it, and we've seen it in a couple of patients. If a patient can identify their trigger, yes, this is a trigger for me, So we've used attenuated androgen for a very short duration of 3 to 5 days during that trigger, and it tends to help. The frequency and the severity of the attack drastically reduces at that point of time. Okay, so this is what we published actually. This is before we used, before we had plasma-derived C1 inhibitor concentrate. So the one case for dental procedure, one for cesarean section, and the third one for an orthopedic surgery. So this is what we used to do. We used to give them a lot of fresh frozen plasma. So all those blue dots are fresh frozen plasma. And then we also used to give them stanozolol and tranexamic acid at that point of time. But now this is much more simplified. You just have to use one dose of plasma-derived C1 inhibitor concentrate just before surgery. And most of these patients do well after that. The long-term prophylaxis, as I said, it is something that you have to decide on a case-to-case basis. To whom you have to give, which drug you use, and for how long do you use. I think there is no question of how long. I mean, if you use it, you have to use it for like almost lifelong. So this is what our recommendations are. As I said, we don't have any good long-term prophylactic treatment as of now in our country. So attenuated androgens or tranexamic acid or a combination of the two would remain the mainstay of treatment for long-term prophylaxis in India. Intravenous plasma-derived C1 inhibitor concentrate may be used in special situations, like if you have a pregnant woman in whom you can't use any other drug, and if this patient is developing recurrent episodes of edemas, you can use that intravenous plasma-derived C1 inhibitor concentrate for maybe a few weeks or maybe a few months. It can also be used in children and adolescents if they continue to have frequent episodes of angioedema despite use of tranexamic acid or androgen or a combination of the two. And this is the dose. You use 20 units per kg twice weekly. That is a challenge. You have to use intravenously such a high dose and every 3 to 4 days. That's a challenge. So one major point, we talked about acquired C1 inhibitor deficiency in association with lymphoproliferative disorders and in association with lupus. For some reason, tranexamic acid as a long-term prophylaxis works very well in those patients. For some reason, we don't know, but long-term prophylaxis in acquired C1 inhibitor deficiency works very, very well. And that should be the drug of choice in these patients. And these are the doses. So we usually start with 1 mg of stanozolol, and then we titrate it depending on the response. We can go down to as low as 0.5 mg alternate day, sometimes 0.5 mg every two times in a week as well. If you are using danazol, so there is hardly any difference between stanozolol or danazol. I mean, in children we use stanozolol, in adults we tend to use more of danazol. So danazol can be 100 mg alternate days to 600 mg per day. Tranexamic acid is 30 to 50 mg per kg per day in 2 to 3 divided doses, with a maximum dose of 3 gram per day. So these are like the standard doses which you can read from the guidelines as well. But these drugs, when you use for short-term, long-term prophylaxis, are not without side effects. With the use of androgen, we've seen all these side effects. So females tend to have menstrual irregularities. Sometimes they just stop menstruating once you're using these androgen. They develop hirsutism, as you can see in this patient. They develop hoarseness of voice, as was shown by in one of the cases by Dr. Sagar as well. Hypertension, weight gain, elevated liver transaminase. These are issues. But yes, I mean, just because these are the issues, we don't stop using these drugs. We still are using, and we've used these drugs in many patients for something like 10 years, 15 years. They tend to do well. They grow well. They get out of this, especially the difficult period during adolescence. And one of the patients actually started developing acne when he was started on these androgens. Tranexamic acid, on the other hand, is very, very safe. There is a very rare chance of thrombosis, and there are some concerns during pregnancy. So in pregnancy, we do not put them on any long-term prophylaxis, even on tranexamic acid. Okay, so there are certain other general recommendations. We talked about triggers, and we tend to ask our patients to avoid triggers. It's not possible to avoid all triggers, but whenever it is possible, we advise them. And we advise them not to use ACE inhibitors and not to use estrogens. And it's very important to participate in the patient support groups. We don't have a patient here right now. I think we invited some of them. But I think one patient is online. I think he's going to share his experience. So there are patients groups available in India as well as internationally. And I can't tell you the importance of, I can't overemphasize the importance of involvement into those patient groups, how helpful they are for these patients. Now, so this is about the management. I will briefly talk about how do you assess the response to treatment. So there are certain assessment tools. just like you use for urticaria or any other disease for that matter. So this is the angioedema quality of life scale. It has 17 questions on a Likert scale of 0 to 4. And then, based on some scoring, you can say that, okay, this patient is leading a good quality of life or not. This is what has been our experience. And you can see, about 38% patients continue to have severe impairment in the quality of life. So this is before the C1 inhibitor concentrate was available. And this is angioedema control test, a very, very simple scoring system, just 4 questions. And, on a Likert scale of 0 to 4, if the score is more than 10, that means the disease is well controlled. And this is again our data, which shows that the quality of life tends to control with angioedema control. So whenever you have a patient, I think these are some of the tools that you can use to monitor the response to treatment. This is my concluding slide, but I have a lot of questions for you after this. So if you want to ask any question, this is your last chance. Yeah, yes, ma'am. So it's available. It is available. It is not available in the routine market. You just have to contact the pharmaceutical companies who are manufacturing it. So there are 2. The third one is likely to be available very soon. The third pharmaceutical company. So you just have to contact them, and they will provide you wherever the patient is. But it's available. It's available in the entire country. And I think I don't know whether you're aware of the National Rare Disease Policy of Government of India. And this disease is now included in the National Rare Disease Policy of India. This happened a couple of months ago. And most of these patients, not most of these patients, many of these patients are accessing C1 inhibitor concentrate through that policy now. So you just have to identify a center who is the nodal center for National Rare Disease Policy, and these patients can easily access treatment through one of those centers. It is a quality drug. It's just of 500 unit vial goes up 20 to 25,000. Yeah. So, but as I said, it's available through National Rare Disease Policy, and it's now easily available. So most of our patients are now accessing through National Rare Disease Policy of Government of India. Yeah. Any other questions? No. There are no predictors, but it is said that if a patient has started developing swelling anything above the neck area, like they started developing swelling in the lips, eyes, then that is very likely, not very likely, but more likely to develop progress to laryngeal edema. So to be very careful with any swelling that is above the level of the neck. But there are no predictors. As I said, this disease is very unpredictable. So if you remember from my slide, like where I showed that mortality data, that families reported death, and when we interviewed those families, they were like, I think most of those patients died during their first episode. So that was the first episode of edema, and that was the laryngeal edema in them, and it just led to death in those patients. So it's highly unpredictable. Some patients do not develop laryngeal edema throughout their life, but some patients continue to have very frequent episodes of laryngeal edema. Some patients have laryngeal edema very frequently, and then for a couple of years, they don't have any laryngeal edema. So what prevents them from having this, what predisposes them to having this, we just don't know. Not prophylactically. I mean, short-term prophylaxis, yes, but not as a long-term prophylaxis. But yeah, short-term prophylaxis. No, we still have to use it. Yeah, we still have to use it. Definitely. Right. No, ma'am. I mean, if you use it on demand, then it doesn't change the frequency of subsequent episode. It's only for that particular episode. No. No. It's only for that particular episode. I can't hear you. Remission period for an acute attack. So it depends how early you use the drug. So the remission could be 1 hour. If you use it, at the onset of the swelling, it could be several hours if you use it at the peak of the swelling. So it really depends on how frequently you use, how early in the attack you use it. So I think these are the concluding slides. This is the concluding slide, and very importantly, do not use steroid, do not use antihistamines, do not use adrenaline in your patients with HAE. They are only going to cause harm. They are not going to cause any benefit. So let's have a few cases. They're all real life cases, and let's see. I'm sure if you get to see patients with HAE, these will be the questions in your mind when you're kind of managing these patients, when you start diagnosing these patients. This is a 35-year-old man, resident of Punjab, who was symptomatic since early childhood, recurrent episodes of swelling on face, eyelid, lips, hands, and feet, frequency about 1 to 2 per month, and you can see in this photograph how swollen he is. He also had recurrent pain abdomen. He also had an episode of laryngeal edema. There is no obvious family history, and he has low C4 level, and he has low C1 inhibitor levels. Now, what would be your next step? Start treatment for hereditary angioedema? Yes, you have to start. I mean, he's having so frequent episodes. Assess the quality of life of the patient? Yes, you have to. Assess the angioedema control? Yes, you have to. Do the family screening. This patient has no obvious family history. Would you still do the family screening? Okay, whom will you screen? Whom will you screen? The children, yeah. So the difference is first degree relatives. So for this, his siblings, his parents, and children. And this is what his tree look like. This is the patient, this is the index patient, and he has 4 siblings. This is what it looked like before screening, and this is what it looks like after screening. His 2 children have the disease. They are asymptomatic, they're still asymptomatic. They are into their first decade of life, but they may be symptomatic at any point of time. So it's very, very important, if you have a patient with HAE, do emphasize on the family screening of the first degree relatives, right? This was case 1. So we have this Master K, 14-year-old boy, resident of Chandigarh, who's come with this swelling. So he was diagnosed to have HAE, who was on treatment. He also has good family history of HAE. You can see many family members affected, and he's genetically proven. He has abnormal laboratory results. And so this patient has come with acute laryngeal edema now. This is not moving. Let's just go to the next slide. This is not working. Yeah, okay. No, there are. No, there are cases from South India as well, ma'am. So we have a big cluster of cases in. It's near Odisha and Andhra border. So there is a very big cluster of cases there, and there are a lot of cases in Chennai. There are a lot of cases in Kochi, for example. There are, I think, more than 50 patients who are being followed up in one center in Kochi. So they are there. There is no actually geographical preference, but yeah, it to some extent depends on the sensitization also. And yeah, so if you start picking up, I think they will be everywhere. Ma'am, consanguinity doesn't matter for HAE. It's an autosomal dominant disorder, so it doesn't really matter for. So what would be your next step? So this patient is a non-case of HAE who has come to you with laryngeal edema now. Let's see the options. You start fresh frozen plasma. Well, you can if there is no other option. Yes, no to hydrocortisone and epinephrine. You give tranexamic acid and stanozolol. Yeah, you'll give long term, but for that particular episode, tranexamic acid and stanozolol is not going to work. Not going to work. Do not even think of starting. give plasma-derived C1 inhibitor concentrated 10 unit per kg. Yeah, so it should be 20 unit per kg. This patient has come with laryngeal edema, so don't struggle with the doses at that point of time. So these are some of the real life cases that you will get to see. So this is what we actually did in this patient. He was given fresh frozen plasma. I showed you this case previously, almost continuous infusion. He was given 20 units over a period of about 2 to 3 days. And this was before we actually had any access to C1 inhibitor concentrate. Okay, go to the next case. This is a 23-year-old female. She's been diagnosed to have HAE, and she's on long-term prophylaxis with tranexamic acid and stanozolol. Now she decides to have a pregnancy. What do? You stop tranexamic acid and stanozolol? Yes, you have to. You can't continue. If you read the literature, the tranexamic acid is said to be, not safe, not unsafe. There are no definite answers on use of tranexamic acid during pregnancy. But in our experience, we've seen at least one pregnancy in whom we continued tranexamic acid, and she ended up having 2 first trimester abortions. We don't know what was the cause, but we stopped tranexamic acid in the 3rd pregnancy, and she did well. So we are scared of using tranexamic acid in pregnancy as well. Do you continue tranexamic acid and stanozolol? So if they're planning pregnancy, androgens must be stopped at least 3 months before they're planning pregnancy. You stop stanozolol but continue tranexamic acid? No, of course no. Stop tranexamic acid but continue stanozolol? No. Counsel not to have a pregnancy. Is that an option? Of course not. Yeah? So we now have better options. We know how to manage this disorder. So we can't counsel not to have a pregnancy, but yeah, we can better manage the pregnancy now. She was discontinued on both drugs. During 2nd trimester, she had, she's the patient. She actually works in police force in Haryana. She's now into her 2nd trimester and she has frequent episodes of angioedema. So what would be your next step? You start tranexamic acid? No. You give fresh frozen plasma during each episode? You can. Of course you can. It is still a very safe drug in pregnancy. You give plasma-derived C1 inhibitor concentrate during each episode? Yes, you have to. And you manage only life-threatening attacks with plasma-derived C1 inhibitor concentrate. Now, option between 2 and 3, 3 and 4 is, depending on the resources. So if you have option, then do give it for all possible attacks. But if not, then you at least manage the life-threatening attacks and the abdominal attacks. Now start long-term prophylaxis with plasma-derived C1 inhibitor concentrate. You can. It's not practical, but it may be required. If she continues to have very frequent episodes requiring on-demand treatment every week, then it is better to put her on long-term prophylaxis for some time if it is available and accessible. Okay, go to the next case. So this is a 4-year-old boy. You can see this edema on the face of this child. Symptomatic since last 2 years. Recurrent episodes of non-itchy swelling involving face, hands, feet, and neck. Approximate frequency is 1 per month. So this is the family tree, and this is a very traumatic family tree. You look at this this child, index child. His father has lost all 4 of his siblings, because of this disease. I mean, very tragic incident in this family. So he was investigated. He has low C4 and low C1 inhibitor level, and he's been diagnosed to have HAE. What would be your next steps? This is a 4-year-old boy. It's a child with diagnosis of HAE with frequent episodes of HAE. You start tranexamic acid? Yes. इनको बोले AC बंद कर दें. It's getting very cold. हाँ, AC. So you start tranexamic acid as a long-term prophylaxis. This patient has very, very frequent episodes, and tranexamic acid is safe in children. It's very, very safe in children. You start tranexamic acid and stanozolol. Well, you can. We have experience of using stanozolol even in young children. They tend to do well. We tend to keep the minimum possible dose. But yes, we will start with tranexamic acid. If this child is not controlled, we will add stanozolol to this child. So this is the better option. So you start tranexamic acid. If the child doesn't respond, then you use add stanozolol to it. Give fresh frozen plasma every week. Is it possible? You can, but it's not a possible option. I mean, I remember 1 or 2 patients who have actually used this treatment, kind of a long-term prophylaxis, but this is something which should be discouraged. It's not a good option for treatment. Can you use start long-term prophylaxis with plasma-derived C1 inhibitor concentrate? Cost and you have to use every 3 days IV preparations, so it's not really possible. So I think this is my last case. This is an 8-year-old girl. It's come from Chhattisgarh, symptomatic since the age of 3, recurrent episodes of swelling, diagnosed to have HAE. She's on long-term prophylaxis with stanozolol and tranexamic acid. Now she needs a dental extraction under general anesthesia. What do? Increase the dose of tranexamic acid and stanozolol. Okay, this is what we used to do when plasma-derived C1 inhibitor concentrate was not available. So the protocol at that point of time was whatever long-term prophylaxis the patient is on, you double the dose 2 to 3 days before, and you continue it for 5 days after the procedure is done. So this is what we used to do when plasma-derived C1 inhibitor concentrate was not available. So you give fresh frozen plasma just before the procedure and repeat it after 2 hours, 12 hours. Well, it is one of the options if plasma-derived C1 inhibitor concentrate is not available. You give plasma-derived C1 inhibitor concentrate just before the procedure and repeat after 12 hours. So you don't have to repeat. As I said, you don't have to repeat. You just have to decide on a case-to-case basis. Yes, give plasma-derived C1 inhibitor concentrate and then wait. Most patients do not need a repeat dose of plasma-derived C1 inhibitor concentrate. So the fourth option is give either FFP or plasma-derived C1 inhibitor concentrate just before the procedure and just wait. And you may repeat if required, if the patient shows any signs of angioedema at that point of time. I think, yeah. So I'm done with the cases and the presentation. Thank you.
Thank you so much, Dr. Ankur, for that wonderful insight. And you made us like KBC, no? All of us are on the tips. Yes or no? Yeah, give him a big round of applause. Huh? Very good. Yeah. Any questions?
Well, it depends on the half-life. Yeah, half-life of the patient, the drug. So you have to repeat it every 3 days.
Two years.
Yeah, so we have the youngest age of diagnosis in our cohort is 2 years.
2 years.
And you use tranexamic acid at 2 years. Yeah. I think this particular child that I showed, 4-year-old, he was started on stanozolol later on. So about 4 years. But the first ever case that came to PGI in 1996. At the age of 3, she was 3-year-old girl at that point of time. She was given androgens, danazol at that point of time. So yes, and she is doing well. She's completely well at this point of time. And she has some attacks, but she's lived her time with those attacks with these primitive options that we had. Yeah, it causes a lot of side effects in females. It causes, so we are worried about using this in females. It causes menstrual irregularities, it causes hirsutism, it causes change in the voice, hypertension. Yeah, it causes in both males and females. But yeah, it is not a very safe drug. So we monitor their liver function test every 6 months. We monitor their weight, hypertension every 6 months. Some of these patients tend to develop transaminitis, and then we end up stopping the drug and then restart once the LFTs are normalized. So not very easy drug to give and monitor.
Dr. Ankur.
So one of those patients, so one was diagnosed in 1996, one was diagnosed in 1999. One of them is like much healthier than I am and much taller than I am. And she was given androgens for a very, very long duration. So she's also working in Haryana Police. The other one, I think, so if there is one paper in your handouts, this is about our experience with 32 patients that we published 3-4 years ago. And in that, I distinctly remember because I only made that table. We've told about the use of androgens in each of these patients, like for how many months was it used, what dose was it used, and what was the final outcome of the height. And as far as I remember, there was not a major effect on the final outcome, final adult height that these patients attained. So yeah, there is a theoretical risk, but you have to balance that risk versus benefit of treating this disease. And I think the benefit outweighs the risk in these patients. Sorry, no cases of? Okay, so we had one patient, and I showed you that case who underwent dental extraction. So she Chhattisgarh. She actually ended up having precocious puberty at the age of 7, I think. And there is actually, in fact, it is possible that if you're using androgen, it should actually delay puberty in these patients theoretically. But she ended up having actually precocious puberty. So yes, it is possible. And when we read, it is possible with the use of androgen that these patients can actually have early puberty. It is possible.
That was my question also.
Okay.
All
Right.
of these children.
Right. So it's available in that handout. So I remember we collected the data of those patients, like how many months, how many doses they received, and what was the final outcome of those patients.
So after the CME, all of us, I think high index of suspicion definitely will pick up and send to Sagar. Yes, yeah.
So have you analyzed the data of the mortality in the ones who have not been treated? Like, I know that our ultimate goal is to prevent mortality only. Like some analysis or history, of course, it will be a verbal autopsy. Like
Right, ma'am.
the ones.
So we analyzed the families who reported death versus the families who did not report death. So there was no difference. We analyzed many factors between these two families, between these two groups, and there was no significant difference in any of the factors. So it was just, I think, delay in diagnosis that was leading to death in these patients. Yes, it is a major trigger. And I know at least 4 or 5 patients in whom the symptoms started for the first time during pregnancy. So I think OBS guideline is a major group that needs to be sensitized. So I think some of these patients have the first symptom in the pregnancy. So pregnancy has a variable effect actually. So if a patient, in fact we published it, we published a data on pregnancy in patient with HAE, and there are several other series. So pregnancy has a variable effect. So one major thing that we learned from when we were writing that paper is we were very worried about the time of birth, like the labor or the cesarean section. But to a surprise, that is the safest period of pregnancy, that they undergo normal vaginal delivery or cesarean section without any risk. And that was the most worrisome thing in our mind. But when we analyzed, it was the most safest period. I think the most troublesome period is the second trimester, and but it is very variable in most patients. So some of these patients tend to have a milder disease as compared to what they used to have before pregnancy. Some patients have the same disease. Some patients actually have aggravation of the disease during pregnancy. It's quite variable. But the delivery is the safest period of pregnancy for these patients. Yeah. Yes. Yes.
So is there any protocol that you follow that
No. No, we don't have. We only give on-demand treatment with plasma-derived C1 inhibitor concentrate or fresh frozen plasma that we used to use previously.
And what about during breastfeeding, sir?
So again, ma'am, we can't use tenazolone. And yeah, I forgot to tell. In fact, breastfeeding is the most difficult period in these patients. So I know of a few females who actually stopped breastfeeding because breastfeeding was lead to very frequent attacks in these patients. So breastfeeding is the most difficult period in patients with HAE. So they have very frequent attacks at that point of time. Yeah. And we can't use androgens at that time. Tranexamic acid is still safe, but not androgens. We have one patient who will share story. He'll talk about the patient support groups. I think that would be interesting to hear. The online? Yeah. So Mr. Gokul is from Bangalore only. He's a patient who is on follow-up with Dr. Sagar. Gokul, can you hear us?
Yeah, doctor, can you hear me?
Yeah, I can. Gokul, we are here. We would like to uh, listen to your experience, and more importantly, we would like to listen to your struggle and how a patient support group in India can actually help, how it has helped you, and how
Yeah.
it helps other patients with this disease.
Yeah, sure, doctor. In fact, I was trying to connect through my laptop. There was some network issue, just opened my mobile. Sorry if the connection is not very good.
That's
Okay,
good.
just to start with the support group, I'll just mention my experience with the support group. I think you already mentioned about that, but just want to highlight and want to thank all of you, especially Dr. Ankur. So we for others who are not aware of it, we do have a separate WhatsApp group for HIE patients and doctors as well, where Dr. Ankur is very active, and there are other doctors as well who are supporting us. In fact, I personally had an experience just to share with all of you. Just one quick incident where the group helped me a lot. Actually, I was traveling from Chennai to Bangalore in a private bus, and suddenly I had a facial swelling attack. Actually, in the bus itself. Actually, maybe there was some trigger. I don't know what happened. Maybe food or something. And it was some. I think it was on a Sunday or something. And in the bus, I remember it was very late. Still, I called Dr. Ankur, and I mean, I'm on the way to Bangalore. I didn't even reach Bangalore. So I called Dr. Ankur, and he immediately, helped me to connect to Dr. Sagar, and that's how I met Sagar in Astra CME. We went directly. My family was here. Actually, they took me to Astra, and everything was ready actually. So this is one of the incidents I thought I'll just highlight. So there are so many other stories you can see in the group actually, where the doctors and even the patient among themselves, they're supporting each other, and it's so nice. And thank you so much, Dr. Ankur, and I would like to share that convey my this thanks to all other doctors as well. I don't know who all are available there actually, but please convey my thanks, and thanks to Sagar as well actually. And this is pretty much about the customer support group. So about my struggle, just few lines about my struggle. I was diagnosed almost 12, 13 years back when I was in my mid 30s, and at that time, as initially Dr. Sagar or Rankur was saying, we had only FFP, and we didn't have this medicine which are currently available. So almost 4 or 5 times I was admitted here. And the one thing which was diagnosed for me is, apart from the things which was mentioned by the doctors, I had a very severe H. pylori infection at that time actually. So I was told that maybe that was one of the reason why I got HAE actually. And just few years back I had and in fact I struggled to get first episode. I'll just add one small thing. I had my first episode out of India. I was in Singapore. I got this episode, and strangely, the doctors there were not able to identify what was the actual reason. So the awareness to be honest, the awareness was much higher in India at that time. So that was good. And so we came back to India, and I was in my hometown Kerala actually. And then after that episode, I was supported by Dr. Sagar, and I kept disturbing Dr. Ankur in many episodes, and got all of the required support. So thank you again, Dr. Ankur, and the whole custom support group. And just last one thing, just few years back, I had a brain stroke. I don't know whether, just 2021, and very strangely after that, I think you saw one of my photos in Sagar's last patient cases. Actually, that was me, and I went through 4 brain surgeries. I had a brain stroke, but strangely, and I didn't have any attack actually till now. After that surgery happened, I don't know whether there's any link. I'm not a doctor, but it's more of a layman term. So I didn't have any attack after that. So it's quite strange, but yeah. So definitely my life is better after connecting with this doctor group, and whole HI training, whatever they're doing, even following it up the government and pharmaceutical companies, definitely helping us. It's helping us to improve our life. And Thank you so much. Yeah, that's it. Thank you. Thank you so much. Yeah. Thanks, Doctor.
Thank you, Gokul. Thank you for sharing your story and thank you for sharing the importance of involvement in the patient groups. We are very grateful for your presence. Thank you so much.
Thank you so much. Sorry that I was not able to join that directly because of my health. Actually, I had to connect online. Sorry, but I initially planned to come there. So sorry about that.
It's okay. Thank you.
Thank you.
So I think just like him, I think we have several stories, and we make it a point to involve patient groups, and we make it a point to always involve pharmaceuticals. This is what I learned through the science of HAE, that you don't learn from books, but what you learn from your patient, I mean, you can't learn from anything else. So we learn from them a lot. I mean, rather than, I think what we give it to them, I think they give much more to us. So we always make it a point to involve patient groups into all our activities whenever we do it. And I think it's also important to have the support of the pharmaceutical industries. I think without them, I think it's impossible to do anything of this sort. So we are almost at the end. We want to have a panel discussion or maybe an open house. So you're free to ask any, and we thank our chairpersons for sharing this. Thank you. So Dr. Sagar and Dr. Sendil and Dr. Sunil Dogra, I think he's still on the way from, it will be, yeah, he's coming from the leprosy conference. So I think, but we are here to answer any of the questions that you have. Sir, please. This is an open house. You can ask anything about HAE or for that matter, allergic angioedema as well, because Dr. Sendil is an expert on that. I don't manage allergic angioedema, but if you have any question related to mast cell mediated angioedema, Dr. Sendil is here. We'll be happy to take any of your questions.
I must say, if you have to ask questions on Dr. Ankur, who is a very close friend. We were actually colleagues at PGH Chandigarh when we did our DO, and currently is based at PGH Chandigarh. He's possibly, I must say, the man who's got the maximum experience of hereditary angioedema at this point in India. His passion, you can say, if he starts speaking on HA, maybe he will be sitting for dinner also today. So, but I think we should take this opportunity to ask questions, and also I think we possibly are able to drive this information that we all are facing these cases, and if we can diagnose them, definitely we can help them. And if there are any questions, we all will be happy to take up, especially on allergies. I think we have the experts here as well. Yeah.
Yes, Neha.
What is your opinion on these food allergies?
See, to basically classify chronic urticaria as spontaneous and inducible. And spontaneous urticaria, you have to consult the patient until it is endogenous. It is nothing to come from outside. It is because of IgE, which is mediated to your tissue factor, your anti-TPO, okay, thyroid peroxidase, and something like that. Nothing to come from outside. The specific allergic is waste of money for the patient. That's what you have to ensure in it. You any sort of a which is required, for example, we have especially usually patient. So we cannot just pay the rate once it is inside the patient room. So his food is not going. So then we try to analyze is what is the reason for the articulate this will be reflected. The serum vitamin D and D dimers. These we do cause or the reason for the persistent of the articulate lesion and our own responsiveness for the initial doses of antihistamines. This is the next meeting.
Sorry, just a minute. I have just a follow-up question on this. Why anti-TPO levels? It's just
Anti-TPO levels because urticaria is of two types. One is an autoallergic Then we have the increased IgE levels, whether it's by the type 2B against IgE receptor or the IgE itself. So in those cases, when we have the utility of blood, require higher doses of antihistamines for the controllers of the urticaria.
Very important point from what Dr. Sendil said. This allergic muscle mediated angioedema is endogenous. There is no allergen that is causing allergy in your body. It is endogenous disturbance in your immune mechanism that is causing this allergic form of angioedema. So there is actually no point of, as sir said, that there's no point of doing these allergy testing in these patients. And don't even try to identify an allergen. Patients come to you, ask you, what is a likely allergen? There is no allergen. It's coming from within your body.
It costs you around 7,000 rupees. So the patient has to waste 7,000 bucks and come to you at last. Yeah.
Generally, what we do is we repeat after 6 months. See, IgE is an indicator to see when higher levels of antihistamines are required for these patients also. Second one, if they are not coming down with the updosed course of antihistamines, they are the next thing for omalizumab. And it's higher level of IgE follows normal with omalizumab. So that's one thing we do. So generally we repeat it after 6 months because it doesn't give a lot of video reports with the penicillin.
Yes,
That was used quite a long time back. Nowadays, we don't prefer HCQS.
Yes, it has been found to be helpful. It does not see like what I try to say is there are omalizumab, it's not a wonderful drug also. Like it does not get the symptoms. Patients do well and who do not do well. So who does well is the one with the higher level of IgEs, but contrarily there are reports with patients with the low level of IgEs done well. The other thing I would say practice not to do food allergy test is because they pick up something and those children get malnourished because of unnecessary food restrictions. And the parents are always behind restricting one food after another. So it's a practical challenge because something comes positive, we are going to react to that. So that is another challenge that we see in practice. Atopy is both are Th2 mediated, like IgE level, IgE mediated disorders. There are high chance of atopic people getting urticaria also. Yeah. That's what. See, if it's an autoimmune urticaria, in those cases, the anti-TPO also will be high and the ANE will be positive. For example, we do ANE in a refractory urticaria, we get the altered D-dimers. Because one of the pathogens, the platelet activating factor is also involved in the pathogenesis of chronic spontaneous urticaria. So in those cases, the D-dimers can be high, so that they are refractory. So when D-dimers are high, we tend to do the ANA levels and the PTINR. Yes, ma'am, I think ma'am has a question. See, autoinflammatory Dr. Divya is spontaneous urticaria. What happens is it is associated with constitutional symptoms. The patients are sick and they associated symptoms are always there in autoinflammatory. So everything is normal. Still you suspect HAE and it is still there. So then you need to borrow the what is it? So that you usually don't get it over here, like it's not seen. think you have pH.
So just one comment. So urticaria, as you raised, is a well-known manifestation of cryopyropathy or a group of autoinflammatory syndromes. But as sir mentioned, I don't think we have only urticaria in them. We have lot more manifestations, and in fact, you have to search for urticaria in them because they will come with lot other problems.
Yeah. Genetic test done for us also from the UK center. So I usually have it this week when basic thing is autoinflammatory is usually having a systemic constitution symptoms will be there, fever will be there, patient having some sort of noise,
Yeah. So the message is that if you have urticaria along with systemic features, and another important thing is the inflammatory parameters are high. Like if you have thrombocytosis, high CRP, high ESR, then this is not chronic spontaneous urticaria. You have to think of an autoinflammatory syndrome in those cases. Talking about autoimmunity and IgE in the context of HAE, if you have a patient with HAE, you do IgE. Most of these patients have elevated IgE. This is not a test that you do routinely, but we do it like because we are in a setting wherein we can do these tests. So if you have a patient with HAE, please don't do IgE. If you do IgE, the IgE will be high. We don't know why these patients have high IgE. There are some studies to suggest that these patients are at increased risk of allergic tendencies. And that is why I think they have food as a trigger, possibly. We are not 100% sure. So IgE is also elevated to some extent in patient with HAE, but it should not alarm you. ANA positivity in HAE we are now currently doing a study on it. Like how common is autoimmunity in patient with HAE? Now, there is a theoretical risk because these patients have low C4 and this low C4 is persistent throughout their life. So if you have it's like a complement deficiency. It's like C4 complement deficiency in their body. And when you have a genetic form of complement C4 deficiency, these patients are increased risk of developing lupus. So that is, with that notion in mind, there are several studies on this that are patient with HAE at increased risk of developing autoimmunity. So we are doing ANA in these patients. We're also assessing systematically if they have an increased risk of autoimmunity. We don't have the results yet, but yes, if you look at the published literature, these patients are at increased risk of developing autoimmune manifestations such as SLE, arthritis as well. And many of these patients actually have ANA positivity as well. So this doesn't hold true for HAE type 3. I mean, HAE type 3 otherwise is not a very big number in the world. And these patients do not have an increased risk of autoimmunity, at least so far what we know. But yes, type 1 and type 2 HAE, which is caused by SERPING1 gene mutation, these patients definitely have an increased risk of autoimmune manifestation.
Are there any signs, warning signs before the attack?
So this is a difficult question. There are no warning signs. I mean, except the prodromes that we mentioned, like they can have a prodromal symptom before they have attack, but that prodrome is also not in all patients. It's seen in about 30 to 40% of the patient in our experience. We are trying to do, I mean, we're doing some test, I mean, we're doing some lab research, basically. It's a research that are there any lab predictors by which you can actually predict the development of an acute attack? So a very good predictor could be assessment of bradykinin or maybe assessment of the bradykinin metabolites. But I think they're all part of research. None of them is in clinical use. So as of now, no clinical predictors for development of an acute attack, no lab predictors for development of an acute attack of angioedema in patient with HAE.
I have a question about sir. You mentioned about autoimmune urticaria. Just out of interest, is the management different from the chronic spontaneous urticaria if I pick up autoimmune urticaria?
Right. No. The intrusion in autoimmune urticaria is they require 4 folds of antihistamine to get under control. They respond very well to cyclosporin omalizumab. That is one thing. Yes, cyclosporin is a drug of choice.
Oral. Yeah, same medicine. Stop or same medicine.
Most of the patients, when we prescribe tranexamic acid, they give us a call. Doctor, whatever you prescribe us, the pharmacists are saying this is used for gynae patients, and this is not. Do you have a gynecological problem? And yeah, so that is true. It's used for that indication more often as compared to what it is used for HAE. Yes, exactly. Yeah.
melasma patients because melasma is given treatment.
Yes. Yes, we do use people who cannot afford to buy cyclosporin. We do use azathioprine. Up to 100 mg a day we go. Yes. 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 Though the omalizumab cost has come less. See, when Xolair was initially in the market, it was 45,000 rupees. Now Cipla has come out with that. Cipla is 300 mg we have to give. It is around 16,000 rupees only. And most of the insurance people have added that. So those who have insurance, you can admit and give them omalizumab. That will be a better one. Because azathioprine, frequently you have to do a blood test to see if it is there or any drop in CBC and things in your reserve. This is more of a safer injection. Like.
Migraine and angioedema episode. I haven't really heard any patient saying that because I had a migraine and I developed an acute episode of angioedema. I never heard it, but stress is definitely a factor, like stress of exam, stress of maybe a fight at home, and so many stresses. Change of season is also a trigger for many patients, especially rainy season. So some patients report that if it rains, if there is a cloudy season, they're going to have an acute attack. But I haven't really heard anybody saying that, okay, I had an acute episode of migraine and that also led to an acute episode of angioedema.
Sujala, you want to give any comments from your experiences, anything? She's from the Bangalore Dermatology Society.
Thank you. So, as we learned from today's talks, yes, HAE is not such a common disorder that we would consider, but we need to have an high in the incidence of suspicion henceforth whenever we come across patients with angioedema, because this is in fact a very life-threatening disease, and a simple, a good look at the history, a good look at the examination, if you do that, we'll be able to save a patient's life. One sec.
So we have finally with us Professor Sonia Dobre. He's head of department dermatology at PGI Chandigarh, and I would request her to give his comments.
So I got late in another small conference at Bangalore. So on behalf of Hereditary Angioedema Society, I welcome all of you. You have been here since morning, and thanks for participating in this small CME. The idea is to increase the awareness about this disease, because even among dermatologists, awareness is not up to the mark. We also started knowing more about this disease when we formed the society. And I think once we know more about disease and when to suspect, we will not be missing our patient, because if you miss our patient, sometimes it can be really life-threatening for the patient. And I think the rest of the activities you must have enjoyed in the day, in the morning. We can continue with some questions which you have. Also, thanks to Bangalore Dermatology Society for being partner with us. Thank you so much for this.
Any questions? Anybody? Or everybody is hungry. We can still have one or two questions if you want. Yeah. Definitely. Some of the photographs of the website are here actually. So these are some of the activities that we've done as part of the society. So you can come and have a look while you're having lunch.
Annual meetings, and then we do some CME workshops also. So if anyone is interested in doing CME any part of Karnataka, during your tenure also, we'll be happy to do it. And otherwise, all of you are welcome to join us in our annual meeting, which this year it is on May 15, May 18 and 19, and we do have good international faculty. And apart from hereditary angioedema, we also discuss a little of urticaria and when to suspect and differentiate the two conditions. So we'll be happy to host you at Chandigarh anytime, any one of you interested. Thank you.
I must say we're blessed because I don't think many companies have a dedicated society for hereditary angioedema, if I'm right. And it's the brainchild of Professor Sunil Rao, Dr. Ankur Jindal, that we are able to actually have this meeting today. On behalf of Aster CME Hospital, I would like to thank all of the who have attended this meeting, and especially thanks to the Bangalore Dermatology Society and the faculty from PJ Chandigarh. And obviously, no meeting can be successful without delegates. And thank you for spending your valuable Sunday morning with us. And so now I invite you all for a lunch. Thank you. We'll have a group photo quickly. Yeah.